Afternoon, everybody. Apologies for the little bit of delay in getting started here, but I think we're all set and ready. Just to start out, I know this is, we're going to be covering some different topics here than we have done in the past. And I really don't have anything, agenda for doing this. It's just more of education for myself and the other committee members. So anyway, we're going to start off with Mr. Drew Snyder. Welcome, Drew, and you're recognized.
Thank you, Mr. Chairman. Is there a white world joke in here somewhere? Huh. Thank you all. Look, after providing a preliminary overview of Medicaid and managed care in Mississippi, I'm going to discuss the evolution of the managed care delivery system here. I'll touch on ways Mississippi is working to drive high performance and accountability from our managed care plans. And after that, I'll discuss the next phase of managed care in Mississippi and future opportunities. At the end, I'll try to offer some observations on an ideal Medicaid delivery system, and then I'll take your questions. Today, the Mississippi Division of Medicaid provides health benefits to more than 870,000 low-income Mississippians, including kids, pregnant women, the elderly, and disabled adults. And while the $6.5 billion Medicaid program is jointly funded by the federal government, by 2015, more than half of Medicaid and CHIP beneficiaries were receiving their services from private insurers or managed care plans. Medicaid eligible children, pregnant women, adult caretakers, and disabled adults with SSI are among the populations required to be members of the Medicaid Managed Care Plan, which has been branded the Mississippi Coordinated Access Network, or Mississippi CAN. Children in foster care and disabled children are among the populations who can elect to join a managed care plan or get their Medicaid benefits through state-run fee-for-service. The Children's Health Insurance Program, or CHIP, includes children from families with incomes higher than Medicaid thresholds, but still under 209% of the federal poverty level. All CHIP recipients participate in managed care. Generally, Medicaid recipients who are enrolled in one of our waiver programs, dually eligible for Medicare and Medicaid, or diagnosed with hemophilia are served through fee-for-service. And for now, most individuals who have maintained continuous coverage because of the COVID-19 public health emergency receive Medicaid benefits through fee-for-service. Under the fee-for-service model, the division, through a contracted fiscal agent, pays providers directly for the covered services they provide. Under risk-based managed care, the state pays the managed care plan a flat fee per member per month, what's known around the industry as a capitation rate, to cover a defined set of services for each Medicaid recipient in the managed care plan. In turn, the managed care plan pays providers for all the covered services a recipient may require that are included in the managed care plan's contract with the state. Managed care plans are at a financial risk if spending on services and administration exceeds payments from the state, and conversely, they are permitted to retain a portion of payments not expended for covered services and other contractually required activities, although there are federal regulatory and state contractual limits on how much can be retained. The capitation rates the division pays to the managed care plans are set by an actuary contracted with the state. Federal regulations require capitation rates paid to the managed care plans to be actuarially sound. That term, actuarially sound, means that state Medicaid agencies have to pay Medicaid managed care plans a rate adequate to cover expenditures for health care services and related administrative expenses. The requirement for actuarially sound capitation rates was put in place in part to prevent cost-conscious state agency heads and appropriators from underfinancing managed care organizations and therefore potentially compromising access to care. So today, managed care operates in what is essentially a cost-plus reimbursement model. That fixed fee or capitation rate is used almost exclusively for the managed care plans to pay the provider. The target expenditure for medical expenses is usually around 87.5 to 88%. And if we include the approximately $600 million in directed payments to hospitals, the medical payout percentage target to providers increases to about 90%. 3% of the capitation rate is set aside to cover the insurance premium tax each managed care plan pays the Department of Revenue. Around between 7 and 8% is the target for administrative expenses to cover staff salaries, IT infrastructure, and other non-claims costs, and the remaining 1.8% is for targeted profit margin. When you hear that managed care plans are paid $3 billion a year, that's how much they are entrusted to administer. How much they keep for administrative expenses and margin is usually well under 10% of that total amount. In some years, like state fiscal year 2018, provider payouts exceeded these actuarial targets, and in other years, provider payouts have been lower. So for the first 40 years of Mississippi Medicaid, fee-for-service was the dominant delivery system in Mississippi. The division, through its contracted fiscal agent, paid providers directly for service. But Medicaid managed care did sprout briefly in Mississippi in the mid-1990s. Around that time, Mississippi and a lot of other states were facing growing Medicaid enrollment and spending, and many viewed Medicaid as a bloated and inefficient welfare program. The state share of Medicaid had grown by over 100% between the mid-1980s and 1990s. So in 1995, the legislature established a voluntary managed care pilot program as an experiment to control Medicaid cost. It was to start in July 1996. Lawmakers came back in early 96 and authorized the program for 11 counties. The program started in Warren County in December 1996 and moved to Harrison and Hancock counties in 1997. Later described as a hissing snake by State Representative Steve Holland, the managed care pilot was short-lived. Now, another managed care program had a slightly longer shelf life. The Health Max program was a separate managed care program without HMOs and without risk. It stood for Health through Medicaid managed access to care and services. It has been described as a gatekeeper program, and beginning in '93, it was targeted at the recipients who qualified for the welfare program once called Aid to Families with Dependent Children. So it provided a physician or nurse practitioner, small per member per month fee to act as a primary care provider. And the Health Max program ended in the early 2000s. Fast forward to 2009, and that year the Mississippi legislature again authorized the division to use a managed care delivery system. This new iteration of Medicaid managed care began as a voluntary program for some of Medicaid's more complex, high-cost populations, disabled adults on SSI, and foster children. The program, launched in 2011 with about 55,000 Medicaid beneficiaries and 2 managed care plans, Magnolia Health Plan and United Healthcare. From 2011 to 2015, managed care population growth was the focus. By 2012, some voluntary populations had become mandatory, and services such as behavioral health had been carved in. In 2015, the Children's Health Insurance Program, a Medicaid-administered coverage, began to operate through the managed care delivery system with 2 MCOs. Shortly before that, in late 2014, the quasi-CHIP category of eligibility was added, increasing Mississippi CAN membership by 30,000. By mid-2015, Medicaid had added around 300,000 children as a mandatory population, and managed care membership swelled to 500,000. Since 2015, no new populations have been added to managed care. But in 2018, the legislature did establish a working group to consider the feasibility of including long-term services and supports in managed care. No recommendation was ultimately made to do so. But services initially carved out of managed care have continued to be carved in. Inpatient hospital services were added to managed care in late 2015, starting with the 2017 contracting cycle. Services in psychiatric residential treatment facilities were carved into managed care, as were services for children with serious emotional disturbances who were served through a community mental health program known as MyPAC. During this time, the focus of the Division of Medicaid shifted from managed care quantity to managed care quality. The division implemented the first managed care withhold payments, where over half of the targeted profit margin was withheld if the managed care plans failed to meet certain quality benchmarks. And in an effort to preserve the over $500 million in supplemental funding to hospitals through managed care, the division also received approval for a quality improvement program called QUIP that enabled participating hospitals to receive additional payments related to reductions in potentially preventable readmissions. During this time, Medicaid also ramped up financial oversight with more robust reviews of managed care encounter data and processes to ensure that the data, both financial and encounter, that was submitted was complete and consistent with MCO financial reporting. The pandemic and the COVID-19 public health emergency have also impacted the managed care program. The pandemic itself initially resulted in utilization plummeting, and this resulted in lower spending for the managed care plans, although initially there was a view that utilization might jump significantly at the height of the PHE. With utilization uncertainty, the division proposed a risk corridor, which was a mitigation strategy proposed to limit the gains or losses a managed care plan could have. We first installed the risk corridor for the last quarter of fiscal year 2020 and have implemented risk corridors each year thereafter. These risk corridors have had the effect of limiting potential windfalls in the managed care program, but they also may minimize incentives for managed care plans to lower avoidable medical costs. While we have maintained a risk corridor during the PHE, it's unlikely the approach will become the new normal. And as part of the Families First Coronavirus Response Act, states have been required to keep individuals validly enrolled for Medicaid on or after March 18, 2020, enrolled for benefits until the end of the public health emergency, in exchange for a 6.2% increase in federal Medicaid funding. While beneficiaries could be moved between fee-for-service and managed care, coverage had to continue even if a beneficiary was found to be ineligible for Medicaid. This continuous enrollment condition has played a large role in the 160,000 additional Medicaid beneficiaries that are enrolled today compared to March 2020. It's also indirectly resulted in some shifts in managed care membership. Initially, the managed care membership spiked because of some of the eligibility work on existing cases stopped in the early stages of the pandemic. But to continue managing an increasing workload, Mississippi began processing certain renewals and redeterminations. And as we found beneficiaries that were no longer eligible under regular eligibility requirements, rather than terminating enrollment, we simply moved these COVID extended beneficiaries from managed care to fee-for-service. We do expect to see an uptick in managed care enrollment in 2023. For a state program to be successful, I think it's critical that everybody does their part. The state Medicaid agency needs to be fiscally responsible, customer-centered, agile, accountable, has to operate at a high level and with high integrity. Managed care players need to share the same features and perform at a level that the state-operated Medicaid program can't. Providers need to be available to Medicaid beneficiaries and to stay up to date on the best care practices. And Medicare beneficiaries also have to be engaged as well. Ascribing any shortcoming in health system performance to Medicaid managed care is scapegoating. Managed care's full potential isn't the role of a piñata, taking swings from people who are figuratively blindfolded and looking for treats. But I can also acknowledge that we haven't reached our true potential for managed care yet. And Medicaid's focus right now is harnessing that full potential for the state. And like a lot of states, it's all about the contracts. We are using our contracts with the managed care plans to set higher expectations for quality and exert more oversight. That's why the division has worked painstakingly for over a year to formulate a new model contract that would strengthen remedies and oversight provisions and also shift a greater focus on quality and care improvement. Everybody recognizes that managed care can't be a fee-for-service look-alike with administrative cost and margin tacked on. We employ a lot of the traditional measures to ensure that managed care plans are delivering value. Several reviews of managed care plans are underway as part of the legislative requirements. We've also independently initiated reviews into administrative expenses, medical loss ratios, subcontractor expenses, and other items. We also have robust liquidated damages provisions in the contract, and those liquidated damage provisions have been retooled with the next iteration of the MCO contract. Most notably, remedies and liquidated damages were completely overhauled for clarity and ease of enforcement. We're in a position now to, or will be, to assess a 1% reduction in capitation payment for the failure of a contractor to meet performance measure targets. We can also assess a 1% reduction in capitation payments for the year if the contractor is found out of compliance by more than 2% during any month of the year for failure to enroll identified members into a care management program. Liquidated damages are not just good for optics. They may inspire some performance improvement. They're not punitive, and for a liquidated damage process to work well, the administrative transactions related to these damages need to be automated and fast. We will also be tying membership assignment to value-based purchasing arrangements. Part of oversight and performance, while the liquidated damages and other penalties provide a stick, value-based purchasing is one of those levers that we can use in managed care that can benefit both providers, members, and elevate quality. For the last 2 years, reacting to the COVID-19 pandemic kept everybody preoccupied. But through that, one of our focuses remained on developing a managed care solicitation that would drive overall improvements in the program. As I said last year, another contracting cycle for Mississippi CAN is probably the most prudent course of action, and we released a coordinated care RFP in December of 2021. For the first time, the division jointly procured the CHIP and Mississippi CAN programs through the same contract. We believe using a single contract will cut down on administrative hassle, make optional oversight more attainable, and spur competition. We assigned internal staff to develop a new coordinated care, the coordinated care RFQ. We conducted external engagement through provider and member surveys, and we were influenced by the 2021 legislative session. I think one of our takeaways from there was that lawmakers supported standardization and uniformity where appropriate. Contractors will be expected to collaborate with the division, in some cases with one another, to create uniform systems that will leverage plans' experience, knowledge, and creativity while providing consistency and ease of administration. Contractors will also be expected to invest in communities through partnerships with other organizations, whether private, state, or community-based, as well as an investment in human capital. The division conducted a rigorous evaluation process over 2022, and in August, we issued notices of intended contract award to 3 of the 5 offers. As I've said to you before, protests are common in managed care procurements, and Mississippi was no exception. Protests have been filed, and my understanding is right now the various vendors who participated in the RFQ are discussing protective orders that will enable them to look at each other's proposals and support any furtherance of the protest proceedings. I don't have an exact timetable there, and probably will be avoiding saying much else on the procurement, since I will be called upon to rule on any direct protests to the division. As we move forward in managed care, I think everybody engaged in the Medicaid program has to think about how to maximize the benefits and mitigate the drawbacks of the design. Now, I've talked to you in the past about some of the drawbacks of the managed care model, the capitation rate setting process, this illusion of beneficiary choice when benefit packages are pretty similar, administrative duplication, less transparency, and the never-ending procurement cycle. And I've also talked to you about a lot of the benefits: directed payment flexibility, administrative flexibility, thought leadership, private sector job creation, and opportunities to better align with social needs. We learned early on in this iteration of managed care that managed care plans can be a valuable conduit for directed payments to hospitals. And under federal regulations, the state, under limited circumstances, is allowed to direct managed care payments to providers. These MCOs can provide a uniform dollar or percentage increase for network providers that provide a particular service under the managed care contract. These directed payment arrangements must get CMS approval each year, but it's allowed us to put nearly $600 million annually into payments to hospitals with the potential for more. I will point out that hospitals do pay an assessment that covers the non-federal share of these payments, but the net to the hospitals participating is still 78 to 84% of gross expenditures. Nothing I've seen at this point has convinced me that hospitals would get that type of financial infusion through fee-for-service Medicaid, which is tethered to some different financing principles in the Code of Federal Regulations. We also tried to keep some of the drawbacks in mind when designing the RFP. Administrative duplication on providers, some of that you're not going to fix, because Mississippi Medicaid, like a lot of other states, has to maintain separate information technology architecture, adjudicate claims, conduct prior authorizations, enroll providers, and perform other administrative functions. And there's a lot of duplication across plans too. And right now, pharmacies have to submit claims to 3 different pharmacy benefit managers. And recognizing that, evaluating the potential trade-offs, we added a provision to have a single pharmacy benefits administrator. And the hope is that it will reduce some of that administrative duplication that providers face without increasing cost or lowering quality. We continue to look at ways to determine how we can harness thought leadership, and the last piece on this, with transparency, I think a big part is reliable data exchanges. So as we move into this next contracting cycle and the onboarding process, one of the big things that we're going to work on doing is trying to get standardization among plans and divisions, so we can get good sets of data that allow us to get common insights. Yes, sir. Yes, sir. Yes, sir. So on the ideal Medicaid delivery system, I don't think there's one right or wrong answer, and I also think it's dependent by state. And I think one of the important pieces to have the delivery system that's ideal, I think one of the things that we've got to have is, at least to some certain extent, a common understanding of what is expected of the Medicaid program. Because I think over time, and depending on conditions at times, that has changed. Is it, if the idea is just to lower the cost to the American taxpayer, a managed care delivery system is probably not the way to do it. I think time has shown that managed care may provide that financial benefit typically provides a financial benefit to the state through some different financing mechanisms, but overall may not save the American taxpayer money. But there's also an opportunity to drive quality and to provide a set of services and interventions to Medicaid beneficiaries that you may not get in one of your more conventional fee-for-service programs. Now, that has to be tailored appropriately to get the value out of those kinds of programs. I think regardless of, and I think where we are right now with incremental improvements and maturity in the managed care delivery system is the most prudent course of action. I think before you make a monumental change on a delivery system model, you've got to have an alternative that works within the various frameworks that are out there. And we can't control what the feds put a lot of rules around different delivery systems, and there's from the Social Security Act to a lot of federal regulations that may or may not allow states the flexibility to do some of the things that you might identify in a ideal system. So I think that probably is somewhat of a theoretical conversation that probably needs to be had over time, and might be a good topic when I pay my $8 a month and get long video access on Twitter Blue. But I think when we've looked at other, there have been flaws in a lot of models. ACOs have had their issues. There's still questions if they work. State-run managed care sounds interesting. The idea that, okay, could you get some of the financial benefits of managed care delivery without without as much cost? But in conversations with people who've tried that in small subsets in other states, it's been very problematic. for quality. So, what I think as the program matures, we've got to look at those things that the state can do cheaper and not any less effective than the managed care plans, and let the state focus on those things, and bring in the outside entities to allow them to really focus on, some of the quality and driving, that care improvement. So, in any event, I'm happy to take questions and elaborate on that a little bit more if you'd like.
I believe you said we have about 870,000 folks covered right now,
That's right.
and that's basically been driven by the PHE, hasn't it?
I think that's correct, yeah.
So if and when the PHE ever ends, I think you told me you're going to have to go back and requalify all these people. About how many folks do you think will fall off?
That is hard. We've looked at it. We don't expect the whole number to drop. And you take 14 months from the end of the PHE. If let's assume growth has been 160,000, and 140 of those were driven by the continuous enrollment condition. I'm just making assumptions. I think you would probably see 2/3 disenrolled. I think some of it may depend, though, on CMS is putting out new regulations that are requiring some additional steps that, while it may not, it may keep people who don't satisfy those traditional eligibility requirements, may keep them enrolled a little bit longer. I think over multiple years, you'll probably see it start to tick back down to that 700,000 number if we don't see other populations added or removed. But and you also may see some drops and then pick back. We're going to start to see a little bit of churn again because people, you'll have these what we call procedural denials or administrative denials where there's not paperwork done within the certain date, but then as people come back and need services, they resubmit those applications and get back on the roll. So it's really hard for me to give a definitive number on that right now.
You had talked about liquidated damages. Can you give me an example of the last time we hit one of these MCOs with damages?
Well, I think one of the we had some, like, let's say a few years back, there one that jumps. There were some issues with compliance around non-emergency transportation, and these were not. It wasn't anything intentional or malicious, but it didn't comply with didn't comply with the contract, and I think that was a high six-figure or low seven-figure number. I mean, sometimes you may see small ones for. I think we've had corrective action plans that were could almost segued into liquidated damages around different claims approval rates, but you see, usually what you see is it's not something egregious. It may be something for somebody didn't update the fee schedule timely as they were required to do in the contract, and they're for each day that's not done, a number goes up. So a lot of different types of things that can come up as non-compliance in a 300-page contract.
Does any other members have questions?
Thank you, Mr. Chairman. Thank you, Drew. and I realize these are just estimates, but I think I heard you just say that we have roughly 170,000, and after the COVID emergency period goes away, it could go down to about 700,000, the more historic number. Did I hear you say that?
I think over multiple years, I think you will see that. You're likely not to see any drop in the beginning because we'll be conducting redeterminations of eligibility for everybody, and there's a process and a certain number of days that you have to go through before you can make those types of things. But yeah, over time, I think you will see you'll see decreases. We won't go back to the levels we were in March of 2020, but I would expect we will be closer to those numbers than we are to the numbers that we look at in November of 2022.
And so what are the categories of people who would be in that group that falls off?
It will be just like, our, I'll explain it, like just every 12 months, there's for most beneficiaries, there's before the public health emergency, you have to redetermine eligibility. And so it may be someone that ages out of a child category, or someone that had SSI no longer has SSI or exceeds in families that exceed income, a whole host of types of individuals that can become ineligible for Medicaid.
Thank you.
Any other questions? Senator Wiggins? Okay. Senator.
Thank you, Mr. Chairman. Mr. Snyder, during your presentation, you mentioned the plummet in 2018. And did I understand you correctly? And the utilization plummeted, I thought you mentioned.
That's right. So when so what happened when the PHE started is with the lockdowns, people stopped going to their regular appointments. Dental offices were closed, and a lot of those preventive. You saw this decrease in preventive services, and because a lot of the Medicaid population is young, we weren't seeing a lot of those hospitalizations because of COVID. We were seeing a lot of children that were staying out of the ER and staying out of these other care facilities. So when 2019 we were seeing a lot, utilization was way up, but by April and May of 2020 it had dropped down. And while it's picking back up, even in 2021, it was still people were still avoiding those medical settings except for these emergent type of situations.
Maybe I'm confused. Did you say 2018 the utilization plummeted?
No, ma'am.
Oh, so it was 20.
2020.
Okay,
It was 2020.
I thought you said something about 2018. Thank you, that's all I have.
Drew, in 2 minutes, can you sort of summarize the progress that you've had changing your computer systems out? Because I know there have been several concerns that providers have called about slow payments and things of that nature.
Yeah, sure. So we procured did a procurement for systems vendor in about 2013, signed a contract in 2017, started work shortly after I got there. In October, we launched our new MMIS system, and I think the launch itself was successful. We paid our first pharmacy claim at 6/14 on October 1st. I think with all of these, there are a lot more hiccups than you would like to see in the stabilization period. So we've got to get system functionality the way where it needs to be, and also the education so that providers, and in a lot of cases, the EDI vendors that submit a lot of these electronic transmissions have a clear understanding of what the expectations are and what the system will do. I think we're trying to be what we would like to see. We want to see this get stabilized, as soon as possible. And I think we will continue, because I think for part of this to be successful, one of the pieces of advice that I've been told is you got to look up in a year and see if our claims pricing correctly and paying right, and then our providers and members having a better experience. But if it can be smoother earlier, I think that will go a long way in building confidence in this change, which I ultimately think will be a vast improvement over what we saw before. But it is going to take a little while to get there.
Thank you. Appreciate it. We have, next up, we have some folks from NCSL. We have Samantha Scotty, who's the project manager, and Catherine Costanza, program principal.
All right, thank you, Mr. Chair.
Ladies, welcome to Mississippi.
Thank you very much. Appreciate it, and thank you, Mr. Chair. As you mentioned, my name is Samantha Scotty. I'm a project manager with the National Conference of State Legislatures, and I am joined by my colleague, Catherine Costanza, a program principal, also with the National Conference of State Legislatures, and we're delighted to be here with you all today. Just a quick reminder, in case you're not familiar with NCSL, we are your national bipartisan membership organization. So we serve all 7,386 state legislators and over 20,000 legislative staff. So our mission is to improve the quality and effectiveness of state legislators, and we do that through a number of vehicles, as you see here on the screen, including policy research and technical assistance presentations like the one we are providing you all with today. And just a reminder, we don't advocate for any one policy option, so we are here to provide nonpartisan information and just a variety of state examples for you all to consider. So we've planned what I hope is an informative presentation for you all today. So I will start with an overview of Medicaid delivery systems, review some managed care history and current trends we've identified, and then I will turn it over to my colleague, Catherine Costanza, to review some state challenges we've heard from states and identify some state policy options and state examples. So with that, I will start with an overview of managed care delivery systems. I know some of this you might be familiar with, but we thought it would be helpful to orient the conversation today. So managed care and fee-for-service are the primary delivery systems that Medicaid programs use. And it's important to note that some states operate these models in conjunction with each other. So as a reminder, fee-for-service models pay separately by service to individual providers, and they're not necessarily managed or coordinated, these services. Managed care is both a payment and delivery system, and it includes states contracting with managed care organizations. And the concept is somewhat fairly self-explanatory, and it involves structured care coordination, ensuring the appropriate services are delivered in the appropriate settings. So most MCOs are private insurance plans that contract with the state agency to deliver services. And so, as Mr. Snyder referenced, most MCOs are typically reimbursed using a capitated reimbursement model. So again, a flat monthly fee paid per beneficiary. And as I mentioned previously, these models can work in conjunction with each other. So we do see some states using a blend of both managed care and fee-for-service. So for example, some states provide services under a managed care organization, but carve out certain services like dental or prescription drugs, or carve out certain populations like those receiving long-term services and supports or foster youth. And then there are, of course, other types of managed fee-for-service models that we will be going over in just a minute. So what is the role of the legislature in relation to both of these models? So the role of the legislature in Medicaid broadly, of course, varies by state. Some state statutes are more prescriptive about Medicaid operations, where others grant executive branch or the Medicaid agency more discretion in Medicaid program design. So legislation can be used to establish different standards for Medicaid service delivery. Specifically, we've seen legislation related to designating the type of service design in the Medicaid program, performance metrics and reporting requirements, network adequacy standards, reimbursement rates, or health plan standards, and of course, program financing. The legislature also does have a role in oversight of Medicaid. So, for example, the legislature may have oversight contracting, particularly in the RFP process, contract management or performance reporting, or they may have a role in performance audits, both related to the Medicaid agency or the health plans. And later in the presentation, Catherine will go over some policy options aiming to improve the performance and transparency of Medicaid managed care. So it is an important difference to notice between these two models is whether the state controls certain responsibilities or whether the state designates some of these responsibilities to managed care organizations. So responsibilities including program operations, provider and beneficiary stakeholder relationships, and certain program integrity responsibilities. So in fee-for-service, the state typically controls these responsibilities, and in managed care, sometimes the state will delegate some of these responsibilities to a managed care organization. So now to dive deeper into the specifics of these different managed care models. So the vast majority of Medicaid beneficiaries are enrolled in a comprehensive risk-based managed care model. And again, this is a capitated reimbursement, so a flat fee per member per month. And as Mr. Snyder mentioned, capitation amounts are required to be actuarially sound, so meaning the calculated amounts should cover the anticipated health services costs, as well as administration, expenses, reserves, et cetera. And this per member per month rate is paid for all members, even if the members do not receive services during a specific month. And it's referred to as risk-based because the MCOs are under contract with the state to pay for these services even if the cost exceeds that capitated amount. That's where the financial risk could come in. However, the MCO can keep any profits should the costs be less than the capitated amount, assuming the MCO meets that medical loss ratio, which Catherine will also discuss more later. But as a reminder, the medical loss ratio is the percentage of collected premiums that are required to go towards actual delivery of healthcare services versus administration or profits. So the intent of this model is to reduce costs and provide better care coordination because MCOs do have an incentive to provide efficient services due to that flat reimbursement rate. Next, we have the primary care case management model, or the PCCM model. This is a managed care model using fee-for-service reimbursement, or managed fee-for-service, essentially. And in this model, enrollees are assigned to a designated primary care provider who is then paid a monthly care management fee for the coordination of services. And this coordination of services can look like the primary care provider referring the patient to a specialist or behavioral health provider, or referring them to social services like transportation or housing. And then there's the limited benefit managed care plan. So some states use managed care organizations to provide a defined or limited set of services like oral health services or behavioral health services, or to serve specific populations like foster care youth. And these are typically paid at a capitated rate, but not necessarily or always at risk as the MCO model is. So this is, of course, different than the models I referenced earlier, where a state would be providing services under the MCO model and carving out these services under fee-for-service. These provide maybe those similar services like behavioral health or oral health under a limited benefit managed care plan. And then, of course, you have fee-for-service, which we have gone over. So which states are using which models? This map here shows the types of delivery systems in place as of 2022. So you'll see here the majority of states use a comprehensive risk-based MCO model, with a handful of states using PCCM model, and then a handful of states in the orange there using a hybrid of MCO and PCCM models. And then in the light white, the states that are operating under fee-for-service. So if you've seen one Medicaid program, you've seen one Medicaid program. You've likely heard this adage before, and it's just a reminder that all state Medicaid programs are very different, and thus the way they design their managed care delivery systems or fee-for-service systems vary quite substantially. So you asked us all to reference some studies and some information related to managed care performance and how certain managed care models compare both across models and states. So there is some evidence indicating that managed care, both the MCO and PCCM model, achieve positive outcomes. It's important to note that these models are highly state-specific and thus might be difficult to compare or generalize across states or across programs. So, for example, state Medicaid programs, MCOs, PCCM entities, these vary widely in terms of the proportion of the population enrolled in Medicaid, or the benefits that these plans cover, or the populations they cover, or the health status of that population, or the reimbursement rates of these plans. So because of all these distinctions, comparing these models can be a little bit like comparing apples to oranges. That's just important to keep in mind as we reference some of these studies. So even though these studies have found some mixed results in the sense that there has not been a definitive conclusion whether or not managed care impacts for the better or for the worse quality of care and costs, here are a few examples relating to studies that have identified some positive outcomes related to managed care. So we've highlighted some of these studies on the slide here, and I will note that we have included sources for these, so we'd be happy to dive into these studies more after this presentation if you'd like. So first, relating to costs, a literature review of several studies found that some states were successful in reducing costs through both MCOs and PCCM models. So the study suggested that improved care coordination, decreased hospitalizations, readmissions, emergency department visits, and better connected high-cost, high-need populations to primary care, particularly in foster care youth. Related to access and quality, the same literature review indicated that managed care models resulted in regular screenings for more individuals, leading to better access to primary care and preventative care for chronic conditions. And then finally, the MCO comparison to the PCCM model. So for the same reason as I just mentioned, it is difficult to compare these two models. And there aren't very many studies that directly compare the two. And some of the comparisons can be difficult because there are a variety of strategies in each model, like care coordination strategies that they can leverage to be more successful. And Catherine will discuss some of these strategies in more detail. But to highlight some positive outcomes, one study did suggest that the PCCM model was more effective at coordinating care for children compared to MCOs, as children in the PCCM model had increased access to and received more care coordination. And another study suggested that MCOs outperformed PCCMs and fee-for-service on a couple of key quality indicators like access to behavioral health and women's health. So again, evidence, and kind of to summarize this slide up, the evidence is somewhat mixed with some positive outcomes to highlight, but it's important to keep, again, these differentiating factors about the models, like who they cover, what care coordination strategies they use. It's important to keep these in mind when evaluating one program against another. And I do understand that you are talking to a handful of states tomorrow, and I think we found some states find more value in hearing some of the outcomes of specific states as they transition from one model to another. That comparison may be of more value. So now on to the history of managed care and some current trends we'd like to highlight. So the use of managed care organizations really took off in the 90s, largely due to increased federal flexibilities, which you'll see here on the slide, including flexibilities allowing states to mandate enrollment in managed care plans, allowing states to implement statewide managed care programs, and requirements allowing states to contract with health plans serving specifically Medicaid beneficiaries. So from 1997 to 2009, managed care grew from serving 8 million beneficiaries to 49 million beneficiaries. And as of 2022, 75% of beneficiaries are enrolled in managed care, with the vast majority in that comprehensive MCO model, about 55 million, and some in the PCCM model, about 5 million. So this map here shows the proportion of Medicaid beneficiaries enrolled in comprehensive MCOs in each state. Onto some current Medicaid managed care trends. So we do see states continuing to increase the use of comprehensive managed care. For example, North Carolina implemented an integrated managed care model to include behavioral health and physical health in July 2021. And Oklahoma intends to transition from a PCCM model to comprehensive managed care in 2024. As I also mentioned earlier, another trend that started in the 90s was carving out specific services, specifically behavioral health, and carving those out from the MCO. And now more states are moving towards fully integrating those services back in and no longer carving those out. So this integration can include integrating Medicaid and behavioral health at the state executive branch level, covering physical and behavioral health under one health plan, consistent reimbursement methodology among plans, or co-locating at the provider level. And finally, and similarly, long-term services and supports. So this includes both nursing facility care and home and community-based services. These have historically also been carved out of managed care, largely due to the high cost and complexity of this population. And now states are moving towards including LTSS back into comprehensive care. So we do see 24 states using managed long-term care as of 2021, and a small number use those limited benefit managed care plans to deliver these services. So you also mentioned that you'd like us to highlight a couple of state experiences that from states that have transitioned from comprehensive managed care to other models. So to highlight just two states here, these are both states that implemented managed care models in the 90s and have since transitioned to other models. So first, Colorado. Payment disputes with managed care organizations led to lawsuits in Colorado, which the state lost. And facing increased and unanticipated costs, Colorado ended its managed care program. And in 2011, Colorado transitioned to a PCCM model, which they call the Accountable Care Collaborative, or ACC model, for physical health, with behavioral health still carved out as a capitated managed care model. And then in 2018, Colorado integrated behavioral health organizations into the ACC model, but still reimburses behavioral health with a capitated model and physical health with fee-for-service. This model does include performance incentive payments, so if certain measures are achieved in the areas of behavioral health, dental, emergency department visits, and well visits. A 2016 evaluation of this program found that the ACC model saved approximately $900 per enrollee annually, and after 4 years of operations, maintained quality standards. Next is Oklahoma. So Oklahoma transitioned to a PCCM model in 2004 due to increased budget pressures and lack of increased provider participation in the managed care organizations. And this is a fee-for-service reimbursement with care coordinations payments per member per month that varies depending on the coordination service. And it has some expanded performance-based components included, which include factors for child screening, cervical and breast cancer screening, and physical inpatient admitting. An evaluation of Oklahoma's program found that the PCCM model increased access and decreased hospitalization and ER visits and improved quality. It is important to note, in 2021, the state legislature enacted legislation which will move the state back to a comprehensive managed care model. So with that, I'm going to turn it over to my colleague, Catherine Costanza, to identify some challenges and state policy options.
All right. So as we start talking about some of the challenges, we're going to talk about both challenges that occur across delivery systems, regardless of whether it's a fee-for-service or a managed care model, or whether it's within delivery system changes, so challenges that can be associated with changes in the delivery system as well. So when it comes to, there are 5 main challenges that are associated with all delivery systems, and I'm going to refer to these as the big 5 throughout this presentation. And they are access and network adequacy, cost, quality, program integrity, and operations and stakeholder relationships. So as I mentioned, these are not unique to comprehensive risk-based managed care and can be found in all delivery systems, including fee-for-service and primary care case management. So we'll discuss more specific examples of exactly how some of these challenges manifest in different systems a little later on in the presentation, in the state policy options section. But there are also some challenges that arise when states change their delivery systems. For example, when they move from a fee-for-service to a managed care model, or when they just integrate significant reforms into their existing model, for instance, within a managed care model. And these challenges fall into these four main categories of timing and capacity, communication and outreach to stakeholders, operations, transition planning, and the budget impact. So as it relates to timing and capacity, any change in the delivery system does require planning and coordination with the state Medicaid agency, as they are typically responsible for the implementation of the new system and may already be navigating pre-existing priorities and deadlines, for instance, those related to unwinding from the PHE and all the redeterminations associated with that. There may also be statutory or contractual deadlines associated with new bidding processes or stakeholder engagement requirements. And that leads us into the second point of communication and outreach to stakeholders. So changes to the type of delivery system will impact every stakeholder differently, and stakeholders require notification to ensure that, to let them know that the existing system is changing and how that change will impact them, and to prepare for that. On the operations transition planning side, delivery system change can impact which organization is responsible for program operations, like beneficiary eligibility determinations, provider enrollment, claims processing and payment, or other core operational functions. And planning for that may, a delivery system change may result in the state assuming some of these responsibilities, or if they are changing between contractors, that can also just be something to plan for. And finally, delivery system changes can impact, obviously, the budget and require fiscal planning. This change to the delivery system can result in a change to the payment methodologies that are put into place or used by the state, a change from moving from a capitated payment that you pay out to your MCOs is going to look different to the state budget than a fee-for-service model. And resources may also be needed to need to be dedicated to support that transition period, as well as fund any new roles or responsibilities that are assumed by the state agency, for example, in a transition from a managed care to a managed fee-for-service model. So California is an example of that touches on several of these challenges listed. So they deliver Medicaid through comprehensive risk-based managed care, and they recently instituted a new statewide bidding process where the managed care plans had to rebid for their contracts. These contracts included new higher quality benchmarks and new benefit offerings that these plans needed to meet. And so preliminary results of the bidding process resulted in 4 existing managed care plans losing their contracts, which they are appealing. As Mr. Snyder mentioned, appeals are common in the managed care bidding process. And if the implementation is not delayed due to these appeals, the plans are also set to switch in the next year at the same time that the Medicaid agency will also be conducting PHE redeterminations and implementing a whole new Medicaid transformation program. So there may be some challenges associated with that. News outlets are also reporting that beneficiaries in California are expressing concern and confusion about the changes to their plans and the changes to the providers within their network and that they currently see. So now we're going to turn our attention to the fun part, which is the state policy options that are available. So one source of state policy options to address the big 5 challenges that we're going to turn our attention to soon are system and payment reforms. And states can implement reform policies regardless of the state delivery system in place, fee-for-service, PCCM, or managed care. As you can see from this map, 41 states and the District of Columbia have at least one type of reform policy in place, and these reforms span all types of models. And we'll provide examples of these in the upcoming state examples section of how exactly states are using some of these. So what exactly are these reforms? Well, reform policies could fill a whole separate presentation, so in the interest of time, we're not going to dig into every single one of these in detail, but as a quick highlight, here I'll outline a couple of these reforms that can be used to address one or more of the big 5 challenges that we're going to talk about. So, patient-centered medical homes are physician-led, multidisciplinary care teams that holistically manage a patient's care. These are often accredited by the National Center for Quality Assurance, and they may be paid, regardless of the delivery system, they will be paid a capitated rate in addition to regular, maybe fee-for-service payment. Accountable care organizations, one of these other reforms, generally refers to a group of healthcare providers or a regional entity that contracts with providers or health plans and agrees to share responsibility for the health outcomes of a defined population. So ACOs, and these are known as ACOs, meet quality performance standards set by the payer and can share in the upside risk of shared savings when they meet those quality benchmarks and are held accountable for those outcomes. And the third reform that I'm going to highlight today, we'll skip the last two. The third reform is all payer claims databases. And these are state-owned databases that include claims data and eligibility and provider files collected from both private and public payers in the state. And this can include Medicaid and sometimes even Medicare claims data and eligibility and provider data. Through data aggregation, all payer claims databases can provide states with insight into costs, service utilization, and the quality of healthcare services across the full spectrum of payers in the state. And all payer claims databases can support state efforts to control costs and to promote value-based care. So you can see how these tools can be used and reforms can be used in a variety of different delivery systems, regardless of the delivery system that is in place. And you'll see, again, some of these mentioned in the state policy examples that come up later. So there are also several state policies that can be leveraged to address these challenges. These are slightly different for comprehensive managed care than for the remainder of the delivery systems. As you heard from your Medicaid director, with managed care organizations and limited benefit plans, the state has contract negotiation and terms, bidding processes, and financial penalties that can be included in contracts to hold managed care plans accountable for compliance with general standards and general state standards, as well as for quality metrics and other things. This is the tool that Florida uses in its Medicaid program in order to hold its plans accountable. You'll see a couple examples coming up, and this is the tool that Florida uses to implement certain penalties on its managed care organizations. And for all delivery systems, including comprehensive risk-based managed care, the policy levers in the right column on that all delivery system slide can be used to address all of the big 5 challenges. But the details will obviously vary and be nuanced based on the challenge that it's addressing. And you may also see other policy options like financial incentives and value-based contracting are going to come up as policy options that can address more than one challenge at a time. And so with that, we're going to dig a little deeper into the big 5 challenges and the policy options specific to these, starting with access. So the challenge of access is, are there enough providers and the right types of providers to serve eligible beneficiaries the scope of benefits offered? Medicaid beneficiaries, particularly children and adults with disabilities or special health care needs, have a harder time finding providers who accept new Medicaid patients and experience delays in getting medical appointments and specialist care. So states have significant flexibility to establish network adequacy standards in Medicaid by, for instance, establishing time and distance standards or tailoring these standards to address different patient populations. So, for example, Georgia has implemented a combination of time and distance standards that differentiate between urban and rural settings and between primary care providers and specialists. States can also establish standards for provider enrollee ratios and the types of providers that can fulfill these standards. So, for example, Florida allows advanced registered nurse practitioners and physician assistants affiliated with network primary care providers to be included in plan ratios for primary care providers. And in order to evaluate and establish standards for network adequacy, states need data to identify enrollee needs, identify provider supply, and then compare and match enrollee needs to available and accessible providers. So states can evaluate network adequacy using independent or state-owned data sets, or implementing new databases to audit, monitor, and identify enrollment, service, and claim and payment trends. So, for example, managed care encounter data, which we'll talk about a little bit later, or all payer claims databases may be used for this purpose and for state monitoring and oversight of Medicaid program network adequacy. So, for example, Washington requires its managed care plans to use encounter data to identify and report on the specialty types of care that provide the highest volume of services, such as cardiology or oncology. And from that, the state can identify specialists that might be candidates for provider to enrollee ratios. And increases in Medicaid payments have also been associated with increases in providers who are willing to accept Medicaid patients, and there are a variety of mechanisms that states can use to direct these payments. In the managed care context, states can use directed payments, but in the fee-for-service context, states can use supplemental payments to incentivize particular types of specialists to join the network if there are particular specialist gaps. I'm going to fly through the next couple of these pretty quickly. So on the next challenge, cost, is the state paying an adequate amount for the covered benefits and services rendered, and is the cost sufficient to support program administration? So cost is obviously a big consideration for the state, as Medicaid is one of the biggest line item budgets in the state budget, if not the biggest. And this is where medical loss ratios are going to come up, and there are some differentiations here between managed care and all the other delivery systems. So as a refresher, the medical loss ratio is the percent of premium revenue the Medicaid managed care plans are required to spend on covered health services and quality improvement activities. And a survey of 43 states conducted by the Office of Inspector General and published in September of this year found that 50% of the reports that managed care providers were giving to states were missing at least one data element necessary for the state to audit and confirm the plan's medical loss ratio. And this report also found that 2/3 of the incomplete reports did not even include fields for the plan to enter necessary information on the form. So for example, so what states can do to address medical loss ratios is standardize reporting forms to ensure that all the data elements necessary to calculate the medical loss ratio are included, ensure that the reports are reviewed for compliance by individuals with the training and experience to review and audit the reports, and there are also steps to validate reported information against other available data sources, such as audited plan financial reports or other publicly available sources. And in the non-MCO world, the other delivery systems can implement value-based payment reforms to control costs. So as a part of its value-based payment reform efforts, Maine has developed a comprehensive rate-setting process to streamline and simplify the way that Medicaid pays providers for services. And so the next challenge is quality. Is the right care being provided at the right time and in the right setting? And there are a lot of strategies that states have, but care coordination, value-based payments are ones that come up pretty regularly here. So for instance, Idaho launched a program designed to link Medicaid payments to actual health outcomes through an accountable care organization model. And Arizona, Arkansas, Massachusetts, and Oregon have recently received approval for demonstration projects to address those non-medical services and social supports into their Medicaid program, including models that are tailored to specific populations such as rural populations or maternal populations. Another challenge is program integrity. So are recipients of state and federal funding acting as good stewards of state dollars? And as I'm sure Mississippi is aware, the spotlight here, there are three components to to program integrity. Fee-for-service payments to providers, payments to managed care organizations, and the accuracy of beneficiary eligibility determinations. But the spotlight has recently been on the role of managed care organizations, as Centene has reached settlement agreements with at least 13 states, totaling $475 million for fraud in its prescription drug and pharmacy benefit programs. And Louisiana recently opened an investigation into United Healthcare's Medicaid managed care programs as well. So this is an area of increasing concern and risk. States are subject to a lot of federal program integrity guidelines, but an Government Accountability Office report found in a survey of 7 states that due to capacity and resource limitations, some state agencies have been unable to implement all of these program integrity requirements or in the process of establishing all of these program integrity requirements. So, for example, Idaho recently started work to perform timely and accurate criminal background checks on providers and its provider screening process to ensure that these are separated out by risk category appropriately. And finally are the core operational functions of the program working. So, and is outreach and communication with the stakeholders effective in preserving those stakeholder relationships. So this can be a challenge regardless of whether the delivery system is fee-for-service or managed care or PCCM. So for example, in Colorado, which is a PCCM model, they have had challenges in significant payment delays for their providers. Florida, in its managed care, managed long-term services and supports plan, recently issued a $9 million sanction against its managed long-term care provider for failing to make or delaying payment on over 100,000 claims. And some of the success stories here are that Ohio plans to implement a fiscal intermediary in fiscal year 2023, requiring all provider claims and prior authorization requests to go through the fiscal intermediary rather than individual MCOs. And so now we're to the state examples. And so this provides just a brief overview of how different states have structured their delivery systems. So Arkansas is interesting because it has, similar to Mississippi, a little over half of its population enrolled in fee-for-service, but the other half are enrolled in a primary care case management model instead of an MCO. And as you can see, they also have limited benefit plans for transportation and dental, and patient-centered medical homes, and all payer claims database delivery system reforms. Idaho is a primary care case management heavy delivery system with 89% of its population covered by case management. But as you can see, it has a wide variety of limited benefit plans and has also implemented patient-centered medical homes and that accountable care organization that we discussed earlier. Maine is a fee-for-service model that has implemented a single limited benefit plan for transportation, as well as a lot of delivery system reforms for health homes, accountable care organizations, and all payer claims databases. And finally, Arizona, which is the longest running statewide managed care program, Medicaid managed care model, with, as you can see, a mix of a little bit of everything. So they have 87% in MCOs. They also have a PCCM that covers their tribal population, and fee-for-service and long-term services and supports in their managed. We have some additional resources included at the end of the slide. And please stay connected with us. We are your professional membership organization. If you need any further information on anything in these slides or anything outside of these slides, please don't hesitate to reach out. Thank you so much.
Thank you, Catherine. Samantha, I got a couple of questions for you.
Both stand here. Sure.
On page 7, or slide 7, I guess. On your comprehensive MCO models, the MCOs are at risk, but then they can also claw back money from the providers, can't they?
So yes, you're correct, and yes, any overpayments that they make to providers, they can claw back. It's usually through their.
Yeah, well, yeah, I'm not going to mince words with you, what they say they overpaid versus what they, if they really overpaid, but I would imagine that somewhere in the contract that we would have with these MCOs is it prohibits them from, if they get penalized, from then penalizing the provider.
That's a good question. It might be within the contracts or within the MCO contract. That's something that we can follow up on. The problem is that contracts between MCOs and providers tend to be confidential or proprietary, and so it's hard for us to see the terms that are in there. That would, I would assume, be a part of the contract between the agency and the MCO, or a state standard that would need to be in place to ensure that managed care organizations are not penalizing providers for any penalties they experience.
I would think, us being the state, we should have access to those contracts, shouldn't we?
You will have access to, I believe, your own managed care contract. The state's access to any of the managed care organizations' downstream contracts with its providers, you'd have to ask your Medicaid agency. I'm not sure if those are always available to the state or to the Medicaid agency.
Right. Under the primary care case management model, I was talking to a physician last week. He's from Florida, and he's transitioned his practice to basically where he gets a capitated payment from the patient. I think he charges, it might be $60 a month, but they can come to him for all their primary care needs. He has reached out to imaging providers and labs to get discounted rates on their work. So basically, other than maybe a patient being hospitalized, he's providing all the care. Are you seeing any of those types of models being developed within Medicaid?
Yeah, and outside of Medicaid, I know that Colorado has explored a similar direct primary care model, but I'll let Catherine comment on inside Medicaid.
So I think the way that this comes up within the Medicaid program, and Sam is right, different states have direct primary care models or concierge care models that are outside of the Medicaid program. Sometimes these are regulated by the Department of Insurance as risk-bearing provider organizations because those providers are accepting a capitated payment, and there may be some financial integrity standards associated with that. In the Medicaid program, this would probably be represented more as a patient-centered medical home or an accountable care organization type model, where, for instance, that patient-centered medical home is a reform that can be implemented where it is a physician-led but interdisciplinary practice and may include other services or other providers that are typically paid a capitated payment rate for the services provided. So there's a lot of different ways that or a similar model can be integrated into a variety of managed care systems or in reforms.
Right. On slide number 10, you talk about some of the positive highlights, particularly with the cost and access to quality. What were the negative highlights?
So we can kind of dive into some of these studies too and provide some follow-up information, but there were some neutral highlights too, so showing as you compare managed care to fee-for-service or across states that there weren't substantial cost savings. So as far as decrease in access and quality and care and costs, there are potentially a handful, but not.
I think there are some, we can pull out examples from the studies that were provided of some of those. And again, these are going to be very state-specific, usually within, there was a decrease within the state, not so much a.
And I think really with the evidence being mixed, again, more so it's that they did not show substantial cost savings as opposed to declines or decreases in cost and quality.
And then on slide 16, did I understand you saying Oklahoma's going back to MCO?
Yep, that is correct. So Oklahoma, in the last couple of years, they did approve Medicaid expansion through a ballot initiative. So we can't comment exactly their motives, but it might be associated with that transition.
So if I'm just sitting here looking at it, PCCM model increased access, improved quality, decreased hospitalization, emergency department visits. I just got to, I got to say this. Are they smoking weed over there?
We can't comment on that, of course, but yeah, I do know that this is quite a lively discussion in Oklahoma. There's actually been some court cases with their transition and some kind of rifts between the executive branch and the legislature on how they are transitioning. So it definitely, there's a lot of attention on that right now.
And then this is the last question I got to ask Catherine. With a name like Costanza, you got any stories for us?
I'm sorry, I do get confused with George a lot. The family resemblance is there, right?
Well, at least you have hair.
Yes, at least I have my hair.
Any other members have questions? Senator Wiggins.
Thank y'all. Excuse me. Thank y'all for a good presentation. So I hope you can understand the question I'm about to ask. But we've heard from Commissioner Snyder and then y'all the historical trends. And so my question is, what was the grand bargain that was done that went from fee-for-service to managed care type plans? At some point, the states were apparently doing it, fee-for-service or whatever. And then all the states, almost, went to this. But yet, we continue to hear different issues, and clearly this is a fluid area. So why was it done in the first place? Can you answer that?
I think that the intent, right, is the concept is to provide better care coordination, better health care quality, and reduce costs. And then, so that was the model, the concept. And then because states had those increased federal flexibilities that were allowed to them, that you'll see here, all through waivers, they were able to transition to Medicaid managed care in kind of larger.
But why didn't states just continue to do it themselves?
I mean, it's a good question. I mean, I think this is part of those challenges being consistent across fee-for-service and primary care case management models. I think there's always a desire to improve cost, access, quality, program integrity, and this was an innovation at the time. A lot of what what the federal flexibilities did is that they made the model financially feasible for the managed care organizations. So for instance, the statewide programs made it easier for the plans to, I think, enroll enough lives to support the program and to dedicate lines of business to just Medicaid managed care and its kind of unique components. I don't know if that.
So in other words, well, no, it does. In other words, the financial incentives put in place by the federal government, which is the payer of Medicaid, certainly in Mississippi, incentivize states to go to managed care type. Is that what you're saying?
Well, and I think it also, so for instance, I think also to get to Chairman Blackwell's question a little earlier about Oklahoma and why it's changing is we're also seeing that a lot of states, when they expand, the expansion population is covered under those managed care plans or has been expanded into that managed care as a way to cover those particular lives and the care associated with those particular populations. So I'm not sure we have better information to provide on kind of that, but we can dig into it a little further and follow up.
And on, going to slide 25, you talked about medical loss ratio. Can you did a formula, can you go back over that, what the medical loss ratio is calculated, how that's calculated?
Yeah, so again, the medical loss ratio is the percentage of collected claims that are required to go to actually spending on healthcare services as opposed to profits or administration. Or it can go to healthcare spending or quality improvement measures within the plan. And that is actually set. It can be addressed in statute or it's federally set. So for commercial healthcare plans, it was set through the Affordable Care Act. And I'll let Catherine comment on how it's under.
What's the standard, I guess, or the acceptable standard?
85%.
5%.
85%.
It goes to the patients essentially, and 15% to
the plans, yes.
to the plans.
And that's the federal standard for the medical loss ratio in Medicaid managed care. And states are able to establish higher medical loss ratio standards and sometimes are recommended to do so depending on the population that's covered by that particular managed care plan. So these can be differentiated by the state between the type of plan that's in place and the populations that are covered by that plan because of what that looks like in the implementation.
So that leads me, okay, so if in Mississippi there is, within our managed care, an 85% loss ratio, that they're within the standard, am I correct?
That's correct.
Oh, 80, okay. And if, all right. So,
Yeah, I believe Director, oh, I'm so sorry.
no, go ahead.
I was about to say, I believe, and I could be misquoting, Director Snyder said that they're meeting about an 87.5% medical
Which is
loss
the
ratio,
standard.
which is the state standard.
If people are beating the drum that the managed care companies are taking all this money, they're actually within the standards that are done under this rate, under this.
Yeah, and, I certainly have no insight into how your Medicaid agency is calculating that. Some of what has been found in recent investigative kind of reporting or reports by the Office of Inspector General is that those are the ratios being reported by the plans to the Medicaid agency, and that there may be a need for validation or oversight of what the plans are reporting, and to ensure that what's being reported to the state is something the data can be independently verified. So I think that's maybe where some of those concerns are coming up, because as you're correctly mentioning, most plans meet the medical loss ratios that are established by the states. There's just maybe a discrepancy in how states can confirm and verify that.
Makes sense. Okay, and then that brings me to the next question. You mentioned it's based on the population that you're serving. And I think others consistently hear from providers about the costs to treat patients in the Medicaid program. I mean, it comes down to numbers. If it costs a patient to give them a shot and it costs $15 and they're being reimbursed at $10, they're losing $5 on every shot that they give. And in parts of this state, we have providers who 100% of their payer mix is Medicaid. So there's this, what I see is this tension that goes on, and we hadn't seemed to have fixed it. Do you have any insight? Because to summarize it, the providers say we're not getting paid enough, and in our statute, under the managed care, they cannot be paid under the Medicaid rate. So they have to be paid at the Medicaid rate. So what's the factor here? What's going on, if you you can answer.
I mean, I think that's a very tricky question, and I know that some of this, is coming from providers. As far as what we could comment on is, as far as the research, right, we do see that there are network adequacy problems and provider retention problems across delivery systems, Medicaid and the private pay arena as well. So, I don't think we are necessarily in the position to comment on the accuracy of that, but we could point to different strategies, for
Okay,
workforce strategies for recruitment, retention.
what are those strategies?
Well, there's a whole host. That's also a whole day of programming, but, there's different, provider payment and education incentives or loan repayment programs, things like that that are related to workforce recruitment and retention. So,
Workforce of the providers or workforce?
yes, healthcare workforce.
Okay.
Yes. So, yes, so as you are saying, we do see that there, network adequacy and provider availability is an issue. And I think, again, we can comment on the strategies, but I don't know if we're kind of in the position to comment on sufficiency of some of those reimbursement rates and things like that.
Yeah, and there's a lot of different payment methodology tools, so I think this is also where people like to turn their attention to value-based payments as an option, or, for instance, in a fair number of states, you see some type of capitated payment, for instance, to that patient-centered medical home in a fee-for-service model. So there can be a lot of different ways that states can, levers available to states to flex the payment methodology. Or I think, as we mentioned in the presentation, and as Director Snyder referred to, there are directed payments that can be made through the managed care program, or supplemental payments in fee-for-service that can supplement particular specialties. There are rules and requirements around that. It's a pretty complicated area, but
If you have a paper on that, or one of your things, I'd like
we
to
can
see.
absolutely follow up on that,
You
and
can
follow
do
up
that.
on
Thank you.
resources related to that.
Appreciate it.
Thank you, ladies. Appreciate you coming all the way out here from Colorado, and hope you enjoy your stay. Thank you.
Thank you so much.
Thank you, Chairman.
Next, we have the Hospital Association, Tim Moore, who's the president and CEO, and Richard Roberson, who's vice president of policy. Go ahead, Tim, whenever you're ready.
Right. Mr. Chairman, I will be brief and will be yielding my time to the counselor here to go through the presentation, but I did want to say or share a few opening comments. And I guess one of the most important ones is I appreciate you and the committee taking time to investigate this further and look at ways that we can make changes in the healthcare industry. I also, I wanted, while Drew was here, to show some appreciation to them, because they have been very good to work with over the last couple of years on supplemental models and looking for other ways to make the system work. And we all know we've got to find new ways to make it work, or we're not gonna survive. I'll say I do think we all need to certainly keep our friends down in Florida in our thoughts and prayers, as they are about to experience the second hurricane in a couple of months. But it has been 37 years since Florida was hit with a hurricane in November. Why do I say that? Well, ironically, that was the same time I entered the healthcare world. I started 37 years ago. Never in that 37 years have I seen hospitals and providers in the crisis that they suffer today, the peril that they are in. Each day, I'll pick up the phone and speak with a hospital administrator, a supervisor, a concerned citizen, and of course, my first thought is, okay, what are we closing today? What services are we eliminating? What hospitals are we closing? I don't know if any of you had a chance to see Becker's Healthcare came out Monday with an article. We have made the top of the list. Out of 200 hospitals on the list for immediate jeopardy of closure, Mississippi has 24 of those 100 hospitals. We are at the top of the list in crisis from a financial perspective in our hospitals. Richard's going to share with you a number of statistics, a number of data points, and share with you a clear picture of where our hospitals are. We certainly know and don't want to take advantage of this, Mr. Chairman. I know you're looking at managed care, and that is a key component in our issue today, and what we're looking at. As we part today, and I know you've got a good group coming in tomorrow to talk in more depth on managed care, but nobody needs to leave here with any misconception that our hospitals in the state of Mississippi are okay, because they are not. It is certainly to a crisis level. There's one answer to that level and that issue, and that it is a revenue problem. Hospitals have cut, they've seen change repeatedly. Commissioner Cheney and I had an opportunity to talk about this some of the other day. Of course, the rates are so much different in what's paid in Mississippi than paid next door. So there are a multitude of issues that bring the problem of revenue, the lack of revenue to our state. So with that said, I would ask Mr. Robertson to follow the presentation.
Thanks, Tim. Thanks, members of the committee, Mr. Chairman, for having us today. We're going to talk a little bit about the hospital situation. I want y'all to level set on where the industry is, and we'll weave into this some of the different delivery models and some of the things that we've been working on with Medicaid. So, again, out of the gate, we've shared this data with you before, but I think it's just important to keep top of mind. Our Mississippi hospitals have the lowest inpatient expenses in the country. Our nonprofits, our for-profits, our state community-owned hospitals are all at or among the lowest cost in the country. So we're doing a good job on holding the line. The next closest state is Wyoming, and it's $150 per day more expensive. And if you look at how we compare to our southeastern state contemporaries, we're not even close. And I would point out to you that Texas, Florida, and Louisiana, the three highest cost hospitals in our region, are all non-hospital certificate of need states. We hear a lot about certificate of need being put out there as a way to lower cost, improve quality. I would submit to you that is a bogus argument, okay? These numbers, these statistics fly in the face of that. So when your three highest cost hospital systems across the southeastern region are in non-CON states, I think that's important to point out. We are totally an outlier among our brethren in the southeastern region. Our cost of living is not all that different from these states, but our hospital expenditures, we're more than holding our line on that. Again, we're 53% lower than the national average on nonprofits, 56% lower than the national average on state and local expenses. Our for-profits who operate across the country, there's a little bit of a narrower window there. They're not as diverse in what they do because they're operating similar cost structures across the country, but we're still 25% lower in Mississippi than the national average for for-profits. Quality is not suffering, so we're providing high-quality care at a low cost. So you're not sacrificing quality for cost. When you look back at the numbers, we're 18th in the state rankings. 35% of the hospitals in Leapfrog received an A grade for hospital safety quality. That's up from where we were in 2021, from 22nd in the fall of 2021 to 18th in spring 2022. The fall numbers for 2022 should be coming out very soon. So, who's paying the bills? For the inpatient mix, I know it's a little difficult to see on this slide, but the inpatient mix, far and away, it's Medicare Advantage, making up almost 44% of our patient payer mix. United and Molina and Mississippi Medicaid and Magnolia get you up to about 21%. Of that commercial insurance, 10% that you see over there, that includes your federal health market exchange, the Ambetter products. United has a product on there too. those are your federal marketplace exchange. So those are a little different than other employer-based care. Blue Cross Blue Shield is about 12% of the payer mix for calendar year 2021. So our Mississippi hospitals, their inpatients, the patients that come to them, this is who's covering them. So it's primarily Medicare and Medicaid, overwhelmingly Medicare and Medicaid. And then what we've also seen is that self-pay / charity number at 9% for 2021. That's because of the extensions under the public health emergency of some of the additional marketplace benefits that have kept people on subsidies, that have allowed them to stay on that marketplace plan when they otherwise might have rolled off and been uninsured. It's also kept people on the Medicaid program when they might have rolled off and become uninsured. So we have seen our self-pay numbers go down a little bit over the last year or two, which is a good thing, to the extent that they're getting some coverage. That's positive for them. It's positive for providers to be able to get paid. So that 9% in previous years has run closer to 12, 13, 14%. So that has been a silver lining in some of the clouds. So on the outpatient side, it looks very similar. It's Medicare Advantage plans. It's the Medicaid plans. A higher percent for Blue Cross Blue Shield, a higher percent for that commercial insurance, again, which includes some of your federal marketplace plans. But the payer mix in Mississippi, our patients in Mississippi hospitals are primarily and predominantly covered by Medicare Advantage, which is a Medicare managed care program, or they're covered by Medicaid, and when I say Medicaid, that includes the Medicaid managed care program. So what are the most prevalent diagnoses? Just the top 4 paid for by Medicaid and the managed care plans are going to be your instances associated with labor and delivery. So it's single, live born, vaginal delivery, C-sections, treatment related to C-sections and scarring, and then sepsis is the 4th highest for inpatient. I mentioned these to show some opportunities for changes in the delivery model. When we talk about value-based programs, and we talk about different things that hospitals in particular can work on with managed care companies, this is one of those areas that can be right for that, because it's what our hospitals are doing primarily for the Medicaid patients and the managed care patients enrolled in Medicaid managed care. So the labor and delivery, the babies, if you look at the top 10 to top 20, many of them are associated. Many of those inpatient diagnoses and claims that get filed are related to moms and babies that come through as inpatients when you're talking about Medicaid and managed care. On the outpatient side, a lot of respiratory infections that come in through, primarily through the emergency department, some through outpatient clinic departments. But when you look at the most prevalent visits and the reasons for patients to come, and this is from calendar year 2020 through the second quarter of calendar year 2022, so for about 2.5-year period, this is what they're running, and it's acute upper respiratory infections, non-COVID acute respiratory infections. We're now coding those differently so that you can distinguish between a COVID case, because obviously the symptoms are similar, contact and suspected exposure to COVID-19 is another one, where they may not be diagnosed yet, but they're coming in with the symptoms and they have identified that they've been exposed. And then just an unspecified fever. Obviously, Medicaid and the Medicaid managed care companies cover a lot of kids. That is one of the largest groups. That is the largest group covered in Medicaid managed care are going to be your children. So a lot of these are going to be kids coming in through emergency departments and for some other outpatient clinic services. These also can present some opportunities for value-based programming, although some of these disease states and diagnoses are a little harder to predict than what you can work with the moms and the babies.
Hey, Richard?
Yes, sir.
Let me just ask you a question. I'm a little confused by the chart. You have the blue line is Medicaid, and then you have Magnolia, Molina, and United. Are those traditional insurance plans, or are they?
Those are your Medicaid managed care plans. Those are your
Medicaid's fee-for-service?
Right. The Medicaid is your Medicaid fee-for-service, and then the other 3 are your Medicaid managed care plans. Yes, sir. Thank you for bringing that Again, going back to moms and babies, almost 35,000 babies were born in Mississippi hospitals in calendar year 2021. 65% of them were paid for by Mississippi Medicaid. That includes the Medicaid managed care programs. About 28% of them were paid for by Blue Cross Blue Shield or other commercial insurance, again, including the Obamacare exchange plans. And about 3 to 4%, I think, were covered by TRICARE, because we do have a pretty strong military presence around the state in different parts, Meridian, Columbus, Hattiesburg, and on the coast, primarily there, lots of coverage through TRICARE. And 5% were self-pay. Those were your uncompensated care, primarily your uninsured. 1% were paid for by out-of-state Medicaid programs. We do have a good number of beneficiaries of other out-of-state Medicaid programs that come to Mississippi for services. It's been probably more predominant Arkansas coming over to Greenville, to some extent Louisiana coming in. So we do have that crossover there as well. And then, of course, Meridian, Tupelo, and on the coast to some extent as well. So Medicaid managed care, Mississippi CAM program. When we look at different ways that we can go about administering the program, we've talked a lot about MLR. We've talked a lot about that medical loss ratio, as has already been mentioned. The medical loss ratio for our Mississippi Managed Care program had followed that 85% guidelines that had come out until a couple of years ago. Medicaid put in the contracts that the MLR, the expected MLR is supposed to be 87.5%. They've got risk corridors in place so that if that MLR does not hit that 87.5 mark, then Medicaid's able to go back and get that money back from the plans. That goes back to Medicaid. Medicaid takes the state money, keeps it in a state account. The federal share of those payments goes back to Washington. So that does not go, does not stay with the plans. It doesn't go out to providers. And so the reason I mention that is when you look at historically kind of where we've been, and this comes from the Mississippi Insurance Department's website. It's a comparison of their premiums paid, losses incurred, netting that out as an admin. But when you look at the percent of losses to premiums, which is a rough estimate of MLRs as reported to the MID, you'll see in 15, 16, 17, 18, and 19, those are pretty consistently hitting the mark of around 90%. What's exacerbated a lot of the problems for providers over the last 2 years, and hospitals being a primary provider that's been hit by this, has been, you've seen less volume coming in. It's not that they changed the rates, they didn't decrease the payments, they didn't, stop paying you $1,000 for something and start paying you $500 for something. It's a decrease in volume exacerbated by the COVID pandemic in 2020 and 2021, which has put them way off of where they have historically been in paying out and the payouts to providers. So what's happened over the last couple of years is Medicaid had to look at clawing back some of the money and sending it back to Washington primarily, because it is about an 84% federal match rate, I think, right now. So that money is going, not going to Mississippi providers, and I'm not blaming the managed care companies for that. That's just, a lot of it is decreased volume, a lot of it decreased access to care. You've had a lot of people die that would have accessed the system that obviously aren't doing that anymore. So you've seen lower volumes and lower payouts. This is not unique to the Medicaid managed care program. You look at this compared to other health insurance plans, whether it's commercial, whether it's Medicare Advantage plans, you see very similar MLRs. It's gone down dramatically from where it was. That's because of decreased utilization. The challenge, though, has been that the costs haven't gone down from the provider side. So one thing, too, to point out, and this is just kind of giving Medicaid a compliment on what they've done, we talk a lot about the payments and the error rates, and are we paying providers correctly? Are the people on the program supposed to be on the program? Are we having eligibility errors? Are we putting people on that shouldn't be on the program? What's going on with that? When you look at Mississippi's overall payment error measurement rate, and this is validated by information that we send, it gets verified nationally. Our payment error measure rate is fantastic. Overall, we're at 8%. Our eligibility error rate, 2.6%, that's excessively below the eligibility rate national average. So we're doing a really good job. Our fee-for-service estimated error rate is 12.3%, which is just below the national average. Our managed care estimated error rate, and I'm not sure why those are like that. I'm not sure if all that's being reported or validated right, but at 0.0%, I'm sure there's some error rate in there somewhere, but it may be lower than the error rate on fee-for-service. I say that to say that, you know, when we talk a lot about Medicaid, we talk a lot about Medicaid waste, fraud, and abuse, and that's not being borne out as a major issue in Mississippi. We're not seeing that from payments to providers that get clawed back, fraud, waste, or abuse, or errors in the payment processing systems in excess of what you see on the national average. Now, Jim Barksdale was my Sunday school teacher in Memphis growing up when he was working with FedEx, and he told a story about how he was in a staff meeting and they were real excited because they had gotten their delivery rates at about a 95% success rate. And of the millions and millions of deliveries FedEx was doing, not hitting 95% of the mark was great. But he talked about the 5% of the customers who were probably really ticked off that they didn't get their package when they expected it. So I say that to say that 12% of the several billions of dollars is not great, but it's better than the national average. So that number continues to get better, and wanted to share that with you. So when you talk about delivery models, the MHAP and the QUIP program, the supplemental payment program that we worked with Medicaid, worked with the legislature on, Chairman Wiggins, when you were chairman of Medicaid, you worked with us on this, transitioning from the old Medicare UPL program to a program based off of the supplemental payments model going through Medicaid managed care programs. We have refined that over the last few years to include a significant piece for quality, so that those payments are not just paid kind of willy-nilly based off claims and volumes. They are paid based off quality and also based off access to care, depending on where those patients go and who's seeing the volume as well. They're divided between these fee schedule adjustments and quality incentive payment programs. That payment pool is now up to about $554 million. That's the difference between what Medicaid would pay and about what Medicare would have paid for the same rate. It greatly helps the hospitals cover that gap. Our outpatient claims payments right out of the gate are pretty close to 100% of the Medicare rate, or pretty close to cost. Our Medicaid inpatient claims typically run about 55% of the cost, and so that's where it significantly helps cover that gap. Hospitals pay the state share for that, so the net is not as great because you're paying a few $100 million to get $500-something million, but it's still a great return for the hospitals and helps preserve access to care for our Medicaid beneficiaries and really for all of us, because you couldn't afford to take a $400 million hit across the industry and still try to make things work for everyone. The QUIP payments over the last couple of years, the quality measures have increased. We're now measuring readmission rates, potentially preventable hospital returns, so that if the hospitals do not hit the mark, do not hit their threshold, they get dinged. They do not get the full portion of their supplemental payment tied to that quality measure, nor will they get it in future years if they don't do a good job preventing hospital preventable complications. So that's another key component, another way that we're working with Medicaid on the delivery model system, putting in incentives to provide care in a quality way, hitting the mark, hitting the goals. I think that's why you're seeing those leapfrog scores go up. It's because of programs like this. Hospitals are getting better engaged with the Medicaid managed care companies. When a hospital's not hitting their mark, or when they're worried about not hitting their mark, they're picking up the phone, they're calling the managed care companies. I've heard stories of several of our hospitals working specifically on inpatient psych readmissions with their managed care providers, and so that's building that partnership because now everybody's got a little risk involved, and I think that's been a really good program. As Tim said, though, our hospitals have kind of gone into from serious condition to critical condition. Prior to the pandemic, we were, as an industry, upside down about $132 million a year. The cost report data for 2020 and 2021 takes into account things such as all the COVID money, all the federal money that was sent, the state money that was sent, some of that's had to be repaid because it could only be used for COVID purposes. So we're trying to sort all that out. It's not great, clean data, but what we're hearing is that that costs have increased a little over 20% on average, but revenue has not kept up with that. Our hospitals in 2021 were reporting approximately $594 million in uncompensated care. That's not all uninsured. That's a combination of uninsured, self-pays, plus folks who had coverage, but for whatever reason didn't pay or receive charity care. So these are the numbers that are presenting the biggest challenge, is that revenue has not kept up. So what can we do about it? We're working with Medicaid on some new supplemental payment models to try to look at paying average commercial rates. Other states have seen success in getting their supplemental payment models to reflect the gap between what Medicaid paid and what an average commercial rate might be. Obviously, average commercial rates are typically going to be higher than your Medicare rate. So if we can base that gap off of the difference between the average commercial rates as opposed to the Medicare rate, that's a big pickup for the industry. We're also looking at potentially reducing or eliminating the hospital provider tax in some way, not permanently, but in a short time frame to help hospitals go through this cost transition period. I think it's important to point out, we talk about doing things differently in the hospital world. You think about 15 years ago, the number of procedures that were done on an inpatient basis, things like hips and knees that were done on an inpatient basis that are now one day or half day going into an outpatient clinic or an ambulatory surgery center, maybe affiliated with a hospital, may not be. Things like that have changed the delivery of health care, not from a payer perspective as much as just from the medical technology and the advances in what doctors are able to do and the equipment that they're able to use. And the incisions are smaller, they're more precise, the recovery and the healing time for the patient is less, so they don't need 2 or 3 days in the hospital. So that's caused hospitals to do away with a lot of the inpatient services and the inpatient staff, focus more on outpatient, and so they have been doing that. That does drive down your cost, but we're still having challenges on the revenue side trying to make that up. Creating low-income payment pools to help subsidize the cost of the uncompensated care that we're trying to address. We're talking about implementing a rural hospital access payment program. Our small rural hospitals are the most at risk, and there's a variety of reasons for that, and most of it has to do with your payer mix. The payer mix that I described here is going to typically be even higher Medicare, Medicaid payer mix for those small rural hospitals. When you get outside of your urban areas, where you get outside of where your large centers where people are employed and have employee coverage are going to be, that's what's going to drive that challenge for the rural hospitals. So perhaps looking at an access payment just to help those rural hospitals keep the door open, or look at ways that maybe through Medicaid we can incentivize that. We're talking with them about that now as we look at new things in the supplemental payment model to maybe recognize and try to give a little extra to the rural hospitals to be able to help them out. Also looking at reducing administrative costs on both the insurance end and on the provider end, not just for hospitals, for physicians and clinics as well, by expediting the prior authorization process or providing gold cards for those providers who are already doing a good job so they don't have to incur additional time, which is money, and staffing to try to chase claims and try to get authorizations approved. Also, bottom line, just increasing the health care coverage. That $594 million a year in uncompensated care, we've estimated would probably be cut in half if we had expanded coverage for those people. That can be through Medicaid, it can be through some other source. But when you look at those items I just mentioned, and you look at the treatment options for the problems that we're having, if you reduce the hospital tax, that's going to be a negative hit on the state. That's additional tax money not coming from hospitals that the state has to pick up. If you increase supplemental payments to hospitals, the impact on hospitals is positive. It doesn't really affect the patients or the state. Same thing with low-income pools. Rural hospital access payments may result in some additional money coming from the state to help those hospitals. The patients, there won't be a financial impact on the patients necessarily. although all of these impact the patients because they get improved access to care. Insurance reforms, again, that's a benefit to the hospitals, no impact on the state's bottom line or the impact on patients from a financial standpoint. But then increasing the coverage through whatever you want to call it, if it's Medicaid expansion, if it's some other version of expanding access to health care, there's a win across the board for patients, for the state, and for your hospitals and other providers as well. So if you're looking at what makes the most sense to try to address some of the problems and the challenges, I would commend that that's probably the best way to go. Finally, just to mention, because this is a current problem, and Medicaid's been working with our hospitals and with other providers on this. Nursing homes are having challenges, individual providers are having challenges, but there's been a conversion from the old conduit system to a Gainwell system. There have been significant challenges in getting paid. There have been claim denials, credentialing problems, delays in prior authorizations, matching up with the claims so that the claim hits before the PA gets into the system, so the claim denies for lack of a PA, even though it's already been there. MPI numbers, coding issues. It's affected long-term care, so nursing homes have had challenges. It's affected hospital crossover payments. This is just the Medicaid fee-for-service payments, okay? This is not Medicaid managed care. That's rolling along doing what it does. But I point those out just to say, I know Medicaid is working on it. They've been really good. We've given them a specific list of things to help with so that they can take those to their vendor and try to get the vendor to help get those straightened out. But this is also causing some significant stress on the system as well because of the financial challenges and what it results in. So I'll stop there and entertain any questions. I appreciate the opportunity.
Thank you, Richard. So going to your slide on your inpatient payer mix, you had the self-paid charity at 9%, but said that in prior years it had actually been higher. Is that right?
That's right.
So then I think you got
It was at 9% for calendar year 2021. In previous years, it's been, close to 15%. Prior to the Affordable Care Act and the Marketplace plans, it was running at about 15%. The Marketplace plan saw a pretty quick drop in that, and then it started coming back up again. So it's probably the last 5-6 year average, I would say it's probably been around 12%.
right, but then you have another, on 15, you talk about the Mississippi hospitals had approximately $594 million in uncompensated care in 2021. Is that reflective of that 9% mark there?
That's the uncompensated care costs. So that is not 9% of revenue. That's the uncompensated care cost attributable to, in large part, that 9% of the patients who are self-pay.
All right, thanks. Does any other members have questions? Senator Blunt.
Thank you, Mr. Chairman. Thank you very much, Richard, for your presentation. I want to make sure I understand the supplemental payment option that you discussed on slide 16. So this would be for people who are currently eligible for Medicaid today and would simply change the reimbursement rate for treating those patients from right now. What is in place today and what could be proposed that would increase the reimbursement rates, not looking at Medicare, but looking at private insurance? Walk me through that.
So back in the 90s, the federal government created an opportunity called the Upper Payment Limit Program, and we, after a few years, jumped in on that. And hospitals have traditionally funded the state share, so the state doesn't pay for that match.
That's Governor Barker did that, I believe, when he was.
Yes, that's the old UPL program, and so the way that worked was it calculated what Medicaid paid for that claim and what Medicare would have paid for the same claim, basically. And so whatever that gap is was your upper payment limit. And that gap is what the UPL program was intended to cover. So it essentially helped bring those rates up to something closer to what Medicare would pay. Of course, you back out what the industry contributes in taxes, and it doesn't, get you quite there, but it's great, and it's helped maintain access to care. What states have just now been able to do over the last couple of years, CMS has started approving going higher than the Medicare rate to what's called an average commercial rate. So you look at the average commercial rates paid in the commercial market, which are going to be higher than Medicare, and instead of that gap filling up between Medicaid and Medicare, now it's between Medicaid and average commercial rate. So that's what we're talking about, trying to do and running numbers to see what that might do. I'll tell you, the preliminary analysis is good. It's not as good as some other states because our average commercial rates aren't as high in Mississippi as they are in neighboring states.
And so if we were to do that, what would be the match on going from the Medicare rate to the average commercial rate? Do you have an idea what that would cost and how it would be paid for?
Well, right now, I think you would still run it through a hospital tax model because that's what the statute says you would do. So we'd probably increase hospital taxes. The way the law reads right now, if we just implemented this program without any change in state law, you would have the hospitals absorb that additional state share cost of probably several tens of millions of dollars to draw down, hopefully, several hundreds of millions of dollars.
And so that would be for under the existing Medicaid match.
That's under the existing Medicaid match, which is around 83, 84% with the public health emergency. Once that goes away, our federal match rate goes back down to around 77, 78%.
And I remember Drew saying earlier that, we anticipate roughly 150, 170,000 people who are currently eligible for Medicaid rolling off as we get out of COVID and out of the emergency, which would just increase your number of uncompensated care by that amount, presumably.
Right. So the concern from the hospital standpoint is, we've seen our self-pay percentage of population of patients go down over the last couple of years, but your uncompensated care cost is still close to $600 million, which is just a little bit less than it was prior to the pandemic. So now when all those people roll off Medicaid or no longer qualify for the marketplace subsidies, I think you will see those self-pay numbers go back up.
Right.
And the cost have gone up. So the cost of caring for that uninsured patient, the cost of caring for any patient has gone up over the last 2 years. So now so that one patient is now going to cost you more. That one uninsured patient is going to cost you more in 2023 than it cost you in 2019 to take care of.
Because of inflation.
Yeah.
And to get back to what Tim said at the beginning, I think I heard him say that there were more hospitals in Mississippi at risk of closure than in any other state in the country, even though we're 1% of the population of the country.
That's right. I think it's 24.
But the hospitals under the supplemental payment option would agree to pay the existing match in order to draw down the federal match and receive the higher, under the UPL model.
That's the way it would work under current law.
Even though
it would be a challenge. It would be a challenge to be able to do that. So we'd have to see what all the final numbers look like. We'd have to model it and then come back and see if that's something the industry can still do. It has been a struggle to pay the hospital tax the last couple of years, even though the tax itself is less than it was prior to the pandemic, and we've had a savings on what we had to pay in hospital taxes. Thank God. But that's going to start going back up once the public health emergency ends, and then you add this on top of it. So just as the state has said we can't afford expansion because it costs too much, hospitals are going to have to make that same analysis to see, even though you're getting a great return, can they come up with that dollar? And that's going to be the challenge, and hopefully we'll be able to do that.
would you rather pay the hospital share of 77% match or a 90% match?
I'd rather pay a 10% state share on that 90% match.
Right. Okay, thank you.
Forgot what I was doing. Senator Wiggins.
Thank you, Richard. For a minute there, I thought you were going to go buy stock in the managed care companies. I was confused. So I appreciate the presentation, and I'm going to disagree with Tim, and y'all know where I'm at. I don't think you have well, you probably do have a revenue problem, but what you have is an innovation problem. But I want to thank you because this is the first time I've heard, certainly in this setting, that y'all have come with these type of suggestions. And it is a real problem about our hospitals. And but it's a nationwide problem that's going on. And I'm not saying anything that anybody doesn't know, but I've been frustrated at the lack of innovation to try to adapt to what's going on by our hospitals. But what you've put up here are things that I think are a good starting point. And like I'll tell you right now, eliminating the hospital provider tax, count me in. I don't know why that was, from a philosophical thing, I don't know where, I understand what it does and I understand the money that it draws down. But I think that's good. And then the part about aligning with the commercial rates makes sense to me. So I appreciate that. But I think if we're to get out of this hole or the issue, we've got to look at operational and innovation. One of the things that intrigued me in the Women and Children's Committee, and I know y'all didn't present it, and I'm going to ask you about it, but I think it was the Department of Health talked about what I'm terming a hub and spoke model of delivery for hospitals. Were y'all there when they talked about that?
We weren't in the room, but yeah.
But do you know what they're talking about? What's your thoughts on that?
What you're talking about there, to some extent, is asking systems to work together or to collaborate on things that they're not in the same organization structure. The hospitals already collaborate across organizations on things like transfers and moving patients to where they need care, and whether it's a bed or an ambulance transfer or whatever. So you've already got that. You've got systems in geographic regions of the state that already work together. But, if you're talking about consolidating services or agreeing to certain hospitals only providing this service, and this hospital is only going to provide that service, and this hospital is only going to provide that service, I don't know that that's possible under some of the antitrust laws, where you might get some anti-competitive issues, where you're divvying up the market, so to speak. So I think you've got to really work through some of those. I think on paper, yeah, it sounds reasonable. In practice, it already works for some things, but it depends on how far you want to take that hub and spoke model and whether those hospitals are all part of the same system and same organization. Because if you've got systems working across each other who are competitors doing anti-competitive things, that may create some problems.
Well, and we don't need to use this time to talk about it, but I think that they came up with that as a solution, or at least an option for us to consider because of the things that we're facing. And being everything to everybody is what, over time, has gotten the hospitals, in my opinion, to this point. They can't be everything to everybody, particularly when, and I'm just throwing out numbers here, when you have 100 people in a county and you have a bed for 250 people or 500 people. The numbers don't work. They just don't work. And I think that's what the Department of Health was saying was, look, we understand this, what you said, the rural parts of this state are suffering the worst. We've got to help them, but having a full-fledged hospital in a county, okay, we know for a fact, because we did the census, the Delta lost 20% of its population in 10 years, okay? How can you maintain the same, and I'm not opining on that, I'm just saying from a numbers perspective, that's a change. So you have to adapt, and in the private sector, that's why I meant innovation. in the private sector, if your revenue is not keeping up, then you innovate so that you can balance your budget essentially. And that's where I've been. But, so I would encourage you to look at that model and let's look at these things, because I think we're getting there. And we can't continue that, but we also have to realize where we are, which I think it sounds like everybody's starting to realize that. So I appreciate you coming with that, with these solutions. Are y'all going to crunch the numbers and present those to us for the session?
We hope to. We hope to.
Does that include the hospital tax as well as the aligning with the commercial rates?
Yes. Yeah. And, yeah, and we have talked about some of these things for several years in different varieties. And I would push back respectfully on the innovation part. Not all hospitals are doing the same thing. If you look at the hospital down in Centerville, it is really different looking than the hospital in Tupelo. They're not trying to be all things to all people, and they're not trying to do everything. Greenwood is not operating a level 1 trauma program. Right now, they've cut back on OB services. Not because people in their community aren't having babies. They are. But they can't afford the cost of that right now, given their revenue and given their payer mix. You don't see a lot of Medicare patients coming in to have babies. So when it's Medicaid predominantly and a few commercial coverage, it makes it really, really challenging. So you don't see a hospital in Sharkey-Essequina County trying to provide, general surgical procedures or run an orthopedic clinic out the back. So they have changed. They've changed a lot over 15 years through technology, through the services that they offer. And they're still the lowest cost. I mean, I keep coming back to that because it is true. The cost is not the problem.
By the way, I thought that was good numbers. I didn't.
Yeah, the cost isn't the problem. You can't go any lower than the lowest on cost. And they still can't make it work. It's a revenue challenge. And so what you're seeing and what you will continue to see is hospitals making decisions just like any other business would. If you're not making money in a certain service line, or you're having to eliminate the cost, then you just get rid of that. So that may make an emergency department close in a part of the state that has an emergency department. So emergency departments are pretty damn expensive. So maybe you just stop providing emergency department services and you just have a hospital that doesn't have an emergency room.
Which is why,
that's
as
gonna
a matter of policy, which is why the feds and are moving people out of the emergency rooms into home-based care and all that. Not only is it cheaper or more cost-efficient, the health outcomes are better is what we've been told.
So, the challenge has been, particularly in some of our rural areas, is finding a rural provider to provide 24/7 care through a clinic model. And Medicaid is reimbursed for that for almost 10 years now. There aren't a whole lot doing it, which again falls back on the hospital with that ER. That's where everybody will come. Well, that may not be an option much longer in some places. And so, from a policymaker perspective, we've got to decide, is that good health policy? Maybe so. Maybe it certainly will fix the cost. I mean, I think you're going to see hospitals just making those decisions that may not be, real popular and probably not what they would want to do if given their druthers. But if they're going to be given a choice of eliminating a service line versus closing the doors altogether, they're going to eliminate service lines. So that's going to be the unfortunate reality.
So last question. The hospital issue, closures and all that being a national issue, have y'all talked to your similar associations across other states? And if so, what, in a nutshell, are they saying are the causes or / what are they doing?
Yeah, it's cost of labor. I mean, it's the inflationary cost of equipment, supplies, food. I mean, everyone's grocery bill has gone up. Hospitals are providing food to their patients, and many of them operate a cafeteria for their employees and for patient visitors. So it's the inflationary cost of all goods and products and supplies, but primarily it's driven by the really, really high spike in the cost of labor, which has not subsided since COVID. And so when you've got these excessive labor costs that are exceeding 15, 20, sometimes as high as 30% if you're still doing contract nurses contract respiratory therapists, your revenue has not gone up 20 and 30%, and that's because,
If your personnel costs are going up 30%, but you don't have a revenue increase of the same amount, which I don't know how you could. I don't know many, I don't know many, other than tech, many people doing that. Something's got to give right there.
right, and so what hospitals have done for the last 2 years is they've made the choice to incur those additional costs to save lives. That's what they did. During COVID, they took the additional costs, which made very little business sense, probably, in a lot of places. They made that choice to save lives, and now they put themselves at risk.
Just to talk to the health systems, the large health systems across the state of Mississippi, all of them are budgeting losses for next year. And it's because of what we're talking about. I was with 6 other southeastern states last week, and we had the same discussion. We all having the same problems. Those that are less, of course, have more revenue that have come through the state, whether that was through expansion, whether it was through the supplemental model that Richard was talking about. Louisiana alone, when they put theirs in, they picked up an extra $900 million. Virginia is about to put theirs in at $1.9 billion. North Carolina is $1.3 billion. That's going to have a huge impact on getting them back.
Look, I'll speak for my own area. I mean, Singing River Hospital has stated the reason they are put themselves up for sale is because they see what's coming down the end, and they have stood out before the community and said, we can't do it on our own, and thus we're doing an RFP and all that stuff. And so I'm confirming, I mean, it looks like that's what hospitals are coming, and they, in their situation, they made that decision because they knew they needed a partner, so to speak. But they're looking at the numbers is what they told us. They said right now they're good, but they won't be that way in 3 or 4 years.
Shout out to that management too, because they've done a great job turning that hospital around.
No, thank you.
Yeah, absolutely.
But I think it's what's going on, is what you're saying, right? Okay. Thank y'all.
Thank you.
Thank you, Richard, and I know Senator Bryan will be having a public health hearing talking about your situation November the 21st at 1 o'clock, 1:15. So I'm sure we'll probably see this again, but that's probably the more appropriate committee to be discussing this. But thank you very much. Next up, we have the Mississippi State Medical Association, Dr. John Cross, who's the president of that association.
Yeah, thank you, Chairman Blackwell. My name is John Cross. I'm an internal medicine physician here in Jackson, and I'm currently serving as the president of the Mississippi State Medical Association. Today, we're proud to introduce and support the strong work and innovative work of Hattiesburg Clinic. They are a national leader in data-driven and physician-led healthcare solutions. So we asked them to present a real-world example of how a value-based managed care program can work here in Mississippi. We have Dr. Brian Batson, CEO of Hattiesburg Clinic, and we also have the medical director, Dr. Dan McCall. Dr. McCall is a graduate of the University of Alabama School of Medicine. He completed his internal medicine residency with a fellowship in endocrinology, metabolism, and diabetes at the University of Colorado School of Medicine in Denver. He obtained a master's degree in science, Master of Science in Public Health at the University of Colorado. He joined the Hattiesburg Clinic in 2003, providing endocrinology specialty care for patients throughout South Mississippi. From 2015 to 2019, he served as the Associate Medical Director of Hattiesburg Clinic's Medicare and Commercial ACO contracts. Since 2020, he served as Medical Director of Value-Based Contracts. He remains very active in the development, implementation, and assessment of the population health efforts at the Hattiesburg Clinic. Dan?
Good afternoon. I want to thank you for allowing us to have this opportunity to share our journey in the delivery of value-based health care. We understand there have been discussions around future Medicaid delivery models, and we recognize that health care is complex and hope that by sharing our real-world experience of our Medicare ACO will be helpful to you as you make decisions concerning the Medicaid program. A little bit about who we are. I think many of you may be familiar with the Hattiesburg Clinic. We were founded in 1963 by 10 physicians and are now one of the largest physician-owned multi-specialty clinics in the Southeast U.S. We have over 300 physicians, over 200 advanced practice providers. We cover 47 specialties in 68 locations spread across 17 counties. We've provided over 800,000 outpatient visits in 2021 and over 32,000 outpatient surgeries and procedures. Our focus today is on our Medicare ACO experience. Some background there, we established our Medicare ACO in 2016. Over the past 6 years, we've provided care for over 45,000 patients through our ACO, and we currently have over 18,000 assigned patients to us. In that time, we've generated over $49 million in savings to the Medicare program. So first, I'd like to start with understanding why we embarked on our transition towards value-based care delivery. And I really would like to start with the traditional fee-for-service healthcare delivery equation. So, and if you'll keep this in mind, later in the presentation, I'll reference it again when I talk about value and the value-based care equation, as there are significant differences. In traditional fee-for-service, revenue is determined by unit cost times volume, and the clinic workflow is based around throughput. So additional revenue is generated by increasing volume of services provided. The focus is often on the patient in front of you, and with physicians often practicing in isolated silos, resulting in marked variations in care delivery. The economic reality of the traditional fee-for-service system in Medicare has been shown as progressive increases in Medicare spending. The graph on the left, you can see the year-over-year increases in Medicare spending. The graph on the right illustrates the corresponding progressive decline in Medicare trust fund balances. So it's pretty clear that this is a seemingly unsustainable trajectory. Around 2010, in an effort to bend the cost curve and maintain the financial viability of the Medicare program, CMS began to transition away from the fee-for-service delivery model and pivoted towards value. So I'd like to spend a little bit of time here setting the stage for our clinic's move towards value. In 2012, in an effort to better understand the cost and quality of the care that we deliver, the Hattiesburg Clinic participated in CMS's group reporting option. The reports generated from our data and the data of other healthcare organizations across the country allowed us to see how we compare to other organizations on quality and cost. We had our first glimpse into our value performance, and unfortunately, we didn't perform well. To orient you on this chart, the vertical axis depicts increasing cost from low to high, and the horizontal axis increasing quality from left to right. The blue diamonds represent individual participating healthcare organizations across the country. The red diamond is the Hattiesburg Clinic. The optimal, desired right upper quadrant identifies high-quality, low-cost healthcare organizations. And of course, that's where we wanted to be. Unfortunately, in 2012, and this was prior to our start of our ACO journey, we were in the bottom left, low-quality, high-cost quadrant. The reality of this data inspired us and really challenged us to transform our care delivery model and really set the stage for our ACO journey. Our opportunity to transition to value-based care delivery arrived with the Affordable Care Act, which established the Medicare Shared Savings ACO program back in 2010. The Medicare Shared Savings program rewards ACOs that lower their growth and costs while providing high-quality care. Here, CMS has taken steps to move away from the traditional fee-for-service equation and move towards a value-based model. So what is value? When we talk about value, talking of quality over cost. So increasing value occurs when providing high-quality, cost-efficient care. Don Berwick, former CMS administrator, and with the Institutes for Healthcare Improvement, conceptualized these basic tenets of value-based care delivery with high quality, low cost, adding patient experience and later provider experience in the quadruple aim. Improving the U.S. healthcare system requires simultaneous pursuit of each of these domains, and they serve as the basic foundation for the creation of the Medicare ACO program. CMS, through their Innovation Center, experimented with multiple different value-based care delivery models, one of which is the Accountable Care Organization model, and that is the one that has since stood the test of time. I'd now like to spend some time discussing exactly what we mean when we talk about an ACO, or an Accountable Care Organization. It's a group of physicians or hospitals that work together to improve healthcare quality, enhance patient experience, and reduce costs. The key word in an ACO is accountable. In this model, physicians are accountable for total cost of care, not just the cost of care that they provide. And for quality, physicians are accountable for all of their assigned patients, not just the patient that's there in the exam room with them at any given time. So ACOs that are successful focus on providing the right care at the right time in the right place. And they do this by coordinating care. That's across both primary care, specialty care, and across settings. So the acute care, the emergency department, hospitals, the post-acute care settings, skilled nursing facilities, home health agencies. There's a foundation of preventive efforts on preventive care and really emphasizing wellness and the annual wellness visit. Chronic disease management, using case management care managers, reducing avoidable emergency department utilization, avoidable hospitalizations, and those avoidable hospital readmissions. Next, I'd like to review for which patients are ACOs responsible. So ACOs are not an insurance plan. Patients don't sign up or join an ACO. Patients are attributed to an ACO based on methodology. Some examples are assignment, which is an automated process. That can be based on plurality of historically delivered care. Some use voluntary alignment, such that a patient designates a primary care physician, and if that primary care physician is a participant in an ACO, then that patient would be assigned to the ACO. It's important to understand that patients retain freedom of choice of providers both inside the ACO and outside of the ACO. Each dot on the map on the right is a patient that's attributed to our ACO. Many of these patients are concentrated in our service area. However, some of the patients may reside outside of our usual service area. It's important to recognize that attribution remains a crucial factor when designing an ACO program. So next, I'd like to review how does an ACO earn revenue. So ACO healthcare providers are still reimbursed through traditional fee-for-service payments. The ACOs are also compensated by the shared savings they create by improving care. It's important that the payers share the totality of claims so that the ACOs are able to guide their transformation efforts. If an ACO lowers healthcare costs while maintaining high-quality care, then the ACO is paid a portion of those savings. ACOs in two-sided risk or downside risk are rewarded with shared savings when costs are below historical benchmarks. However, they are responsible for paying a portion of losses back to the payer when costs are higher. At the beginning of the presentation, I reviewed the fee-for-service equation, and now I'd like to introduce a new concept on the value performance equation. This equation looks very different from the traditional fee-for-service. We start with a financial benchmark. You can think of this as a budget. It's based on our historical costs. The benchmark is then risk-adjusted by the current ACO population's demographic and medical conditions. This accounts for any change in the illness burden of the current population compared to that of the initial financial benchmark population. Medical expenditures are then subtracted from the risk-adjusted benchmark. Many of the higher cost expenditures occur in the acute setting, the emergency departments, the hospitalizations, and readmissions, along with post-acute care space, including skilled nursing facilities and home health agencies. Finally, quality serves as a modifier or threshold to receive any created shared savings. In summary, to generate shared savings, the current healthcare costs of the ACO attributed population must be below that of the risk-adjusted financial benchmark while providing high-quality care. The structure of the Medicare ACO shared savings program is based on a glide pathway. Initially, it's upside only, so there's no downside risk, with progression or glide towards accountability for shared losses. In this program, ACOs start at level A or level B. And initially, they have a shared savings opportunity of 40%, again, with no downside risk. As an ACO continues in the program, they advance towards risk, with risk starting at level C. At that point, the shared savings rate increases to 50%. However, there is a shared loss rate of 30%, which is capped at 1% of their benchmark. The Hattiesburg Clinic ACO is currently basic track level E, with a 50% shared savings opportunity and a 30% shared loss responsibility. In addition, we're eligible for other incentives, such as the skilled nursing facility 3-day waiver. As you can see, there are progressive increases in max shared loss cap as ACOs advance in the glide pathway. CMS continues to incentivize new ACO participant physicians with upside-only opportunity, and then it advances them to risk as they mature in the program. So I've reviewed the financial aspects of an ACO. Now let's review the quality. We must meet or exceed the quality performance threshold to be eligible for any shared savings. These are the quality measures for our Medicare ACO. They include patient survey, patient experience, hospital admission and readmission rates, chronic disease management, performance in areas such as diabetes, hypertension control, and depression, preventive care process measures, including fall risks, assessments, flu shots, tobacco screening and counseling, cancer screenings for colon and breast cancer, cardiovascular disease prevention, and depression treatment. The selection of relevant and appropriate quality measures are crucial to the success of an ACO program design. We've participated in multiple value-based plans, and over time we've seen a refinement and an overall gradual reduction in the number of quality measures. These Medicare ACO quality measures have withstood the test of time as reliable indicators of healthcare quality. So now that we've reviewed the basic mechanics of ACO arrangements, I'd like to focus on how we transformed our healthcare delivery system to be successful in these value-based plans. No longer are we focused on throughput, but instead on a holistic patient approach, focusing on all patients in our panel all the time. We expanded our care teams, recognizing that physicians alone don't have enough time in the day to provide all the needed care to be successful in these models. We utilize standardized evidence-based care algorithms. We coordinate transitions of care through all aspects of our healthcare delivery system. So we've completely re-engineered our care model. And I can't emphasize enough how different value-based care delivery is from traditional fee-for-service. This slide details our care delivery model. We assembled a team approach, keeping the physician at the center. We focused on a foundation of wellness and preventive care. We developed and implemented chronic disease management teams in areas such as diabetes, congestive heart failure, and chronic obstructive pulmonary disease. We focus on behavioral health and social determinants of health and coordinate transitions of care in the acute and post-acute care settings. It's been an organizational-wide effort. This slide again shows how massive a transformation this has been for us, and as we've learned to care for the patient wherever they are in the healthcare journey. So let's take a look at the people that are doing the work. This is our quality management department. We have 5 ACO registered nurse case managers, 13 registered nurses performing annual wellness visits, that preventive care, 12 nurses performing chronic care management services. This is for patients that have diabetes, heart disease. 3 transitional care management nurses that are helping to case manage those patients coming out of the hospital and helping them transition back to their home. And then 3 value-based advanced practice providers. In the past 12 months, we've performed over 12,000 annual wellness visits. We have over 4,700 patients currently enrolled in our case management program. And we have over 5,000 patients who have received transitional care management coming out of the hospital just in this year. These are the talented individuals that are required to manage the over 40,000 patients that are in all of our value-based plans. In addition to the people, we needed standardized care processes. We took 4 of the most costly chronic diseases, high blood pressure, depression, diabetes, and heart disease. We built standardized workflows to reduce variance in care delivery. While these processes are appropriate for the majority of our patients, we recognize that each patient requires individual care considerations. We built analytic dashboards to monitor our progress and perform audits to identify areas for improvement and optimization. We attribute much of the success of our ACO to these care protocols. We provide evidence-based clinical therapeutic guidance to our physicians. This is an example of a care pathway and treatment algorithm for hypertension. In addition to the people and the processes of our ACO, we developed care management teams. This is an example of our expanded care team, our chronic disease management, CCM team. This team provides case management for patients with 2 or more chronic conditions. The CCM program has been shown to save Medicare $74 per patient per month. We internally have demonstrated a 25% reduction in hospital readmissions for patients that are managed in this program. In addition, it allows us to expand our care team as the nurses providing these services can help close 8 of the 10 quality measure gaps for our Medicare ACO. And this is an example of that care team expansion that's working side by side with our physician to take care of our patients. Likewise, our transitional care management team identifies patients recently discharged from the hospital. We're making sure that they understand their post-discharge treatment plan. We're working with them to make sure that they're able to get their medications and that we get them in to see their primary care physician or appropriate specialist within 7 days of discharge. For those patients that can't come into the clinic to see us, we're back performing house calls. So we have an advanced practice provider that goes to their home. In a typical day, our nurse practitioner will see 8 patients in their home during this very vulnerable period out of, after recent hospitalization. So why invest in transitional care management? The average cost of a hospital readmission is around $15,000. This is higher than what the typical initial or index hospitalization cost would be. Our TCM program for patients that engage in it reduces the risk of patients going back to the hospital by 50%. And they do that by that intense case management, reaching out and contacting the patient within first 48 days and getting those patients seen by their physician within 7 days. And again, if they're not able to do that, then we go to their homes. So we transformed our care delivery model, and I'd now like to show you how we did after doing so. From a financial standpoint, over the last 6 performance years, our ACO has saved Medicare $49 million, which we're very proud of, but most importantly, we've done that by providing better care. You recall this slide, it was our first glimpse into the quality and cost performance. With the transformative changes that we put in place throughout our ACO journey, we progressively moved from that high-quality, low-cost quadrant, otherwise known as the high-value quadrant. Since that time, our patients have experienced further improvements in cancer screening, chronic disease management, and preventive care. So in addition to saving money, we continue to save lives, and we're honored to have been ranked as the top ACO for quality in the country. So what's next? We realize that this has been a tremendous undertaking, and that we're still very early in this journey. Emphasizing the continued move towards value, the CMS Director of Medicare published an article in the New England Journal of Medicine earlier this year, declaring CMS's goal of having all traditional Medicare beneficiaries cared for by providers in accountable care arrangements by 2030. We are one of many organizations that have had success in the Medicare ACO program, and CMS remains committed to seeing this model thrive. Clearly, CMS and Medicare believe in the future of ACOs, and that brings us to why we're here today. Medicaid ACOs have been tried in multiple states, and as you can see, they've been geographically spread across the country. In addition to other states, such as Alabama with their Alabama Coordinated Health Network, and Louisiana have developed similar value-based care models. Unlike the Unified Medicare Shared Savings Program, each of these state Medicaid ACOs utilize different financial and quality methodologies specific to their unique challenges. Although these Medicaid ACOs are unique in their design, many share common characteristics. This table, published in the Milbank Quarterly, focused on 4 states with Medicaid ACO programs. This was published in 2019. Massachusetts, Maine, Minnesota, and Vermont, with ACO experience dating back to 2011. As you can see, each of these states has more than one ACO offering. 2 of these states, Massachusetts and Minnesota, have Medicaid ACOs, which are coordinated with their Medicaid managed care organizations. All 4 calculate shared savings based on retrospective total cost of care with quality assessment. 2 of the states have downside risk, in Massachusetts and Minnesota. Massachusetts and Vermont both provide prospective payments to their ACO providers. Notably, all 4 states sponsor health information exchanges, which are crucial for helping guide transitions of care. Several states also offer quality and cost reports to participating providers. Again, states such as Louisiana and Alabama also share some of these characteristics in their value-based Medicaid plans. So these are some of the factors which are important to consider when creating a successful and sustainable ACO model. The slide's not advancing, but I'll continue if you've got the... I'd like to now review the impact of social determinants of health on healthcare quality and cost. There we go. Thank you. Despite traditional healthcare delivery focus being on clinical care, social determinants of health influence half of health outcomes, as published by the National Institute for Healthcare Management Foundation. As you know, food insecurity, transportation challenges, and community safety needs are associated with increased emergency department utilization. The National Association of ACOs has emphasized the importance of addressing social determinants of health in Medicaid ACOs, declaring many states that organize their Medicaid programs around the ACO model for care delivery have identified social drivers, determinants of health, as a critical problem. Improving health equity and addressing social determinants of health are critical to delivering high-quality care in a cost-efficient manner. So it's important to keep these in mind when, again, considering design of a Medicaid ACO. So in conclusion, The Hattiesburg Clinic has spent over 6 years in our value-based care journey with our Medicare ACO, also with multiple Medicare Advantage plans, commercial ACO agreements, and our own employee health plan. We've identified these factors as crucial to design and implementation of a successful, sustained ACO. The first, attribution, and I discussed that earlier, but these are for which patients are an ACO responsible. The next, benchmarking, so how to accurately determine historical cost, the truncation of extraordinarily high-cost claims, how to update the benchmark, including any regional or statewide cost trends, and accounting for previous created savings. Risk adjustment, how to adjust the benchmark for the current illness burden of the attributed population. It's important to avoid disincentivizing taking care of patients that have complex problems, and this is where risk adjustment is very important. Financial reconciliation methodology, whether upside only or transition to downside risks, savings and loss rates, and minimum savings and loss thresholds, shared savings and loss caps, in any interaction with quality performance. Information technology, reporting, and analytics are crucial, so being able to provide accurate and timely attribution, cost and utilization, and quality performance reports are crucial to guiding successful care transformation. Quality measures and evaluation, again, I discussed that in detail, but it's important to be able to select meaningful measures, setting performance benchmarks, and recognizing quality improvement. Care team redesign, so support for those expanded care teams, whether it's chronic care management or annual wellness visits or transitional care services. Addressing social determinants of health, behavioral health integration, aligning with mental health services, and fostering the integration of behavioral health into primary care. Claims data sharing, again, very important. ACOs need access to the totality of claims to be able to identify opportunities for savings. Healthcare information exchange, so the real-time notification of emergency department visits, hospitalizations, and skilled nursing facility admissions and discharges. These notices are vital for our transitional care management programs so that we can intervene and help these patients in a timely fashion. And finally, and most importantly, aligning stakeholder participation incentives. So building a program that incentivizes new ACO participants while also fostering continued participation in the program. So in summary, model design is crucial to sustained success, and I want to thank you for the opportunity to be able to share our experience today.
Dr. McCall, I want to thank you. That was an excellent presentation. Tremendous amount of information in here. And also congratulations to you and your staff for the #1 ranking in the country. Have you talked to Medicaid about your findings?
So we have, Medicaid has visited us before and had an opportunity to hear our journey. And so, yes, and I think, we continue to learn from them and the challenge, and we recognize that the populations, although they do intersect, many of the patients in our Medicare ACO are dual eligible, but also realizing that there are other populations that don't, as you've discussed earlier today, such as the infants and children in maternity care.
Sure. Well, you're doing basically what our MCOs should be doing. But thank you for that. I just have one question, and that has to do with your social determinants. When you find these situations, what resources do you guys go to try to remedy them?
Yeah, it's a great question, and it's a challenge. I mean, this is a significant challenge. So the first is we leverage the talents of our care team. So we utilize social workers that are educated in community resources. We utilize health information technology that's out there There's sites, Aunt Bertha, these sites where you can go in and enter a patient's location and get a lot of detail around food resources or transportation that's available. We spend a lot of time around coordinating care. And so whether it's the transportation company to make sure that the patient, I'm an endocrinologist, a patient with diabetes that lives in a rural area can come out and see us. We have leveraged telehealth, and the pandemic really pushed us along with that. But again, realizing that there are patients, that cost of gas alone can be a barrier. But if, they're able to do a telehealth visit, then we can help close that gap. We're also embarking in a collaborative with the American Medical Group Association, looking specifically at cardiovascular disease risk reduction in populations that are at highest risk based on social determinants of health. So we continue to work with other organizations across the country and try to look at kind of best practices and share those so that we can try and close these gaps. But it's not easy.
Any other committee members with questions? All right. Thank you, Doctor. Appreciate it. Well, that should conclude today's hearings. We'll be back tomorrow about 9:30. We have 4 different states that are going to present from their Medicaid perspective how they manage either